Good morning, everybody. This is Alicia Clark, and I'm the Assistant Director of Community Planning and Collaboration for the Department of Mental Health and Addiction Services. And I'd like to welcome you today to our Crisis Academy. Today's Crisis Academy is going to concentrate on mobile crisis. And as you know, the department has invested in crisis services for a long time, and we are so grateful to have this opportunity to learn together and to hear from national partners on the best practices across the country on crisis. Crisis has been one of the priorities of our governor and priorities of this department and our director, Lori Chris. And it is just my pleasure to continue to work with partners such as the PEGS Foundation and Tom Craig, OACBHA and Sherry Walters and her team, the Ohio Council, and Teresa Lampo and her team. And so we've had such a robust collaboration going, and this is a wonderful next step to how we are working together to partner with the community and provide education and best practice learning. So with that, I will turn it over to Joyce. I just want to say thank you and welcome to the Crisis Academy.
Good morning, hello, and welcome again to the Crisis Academy on Mobile Response Teams for Adults and Youth. I am Joyce Starr, and I am the Chief of Recovery Support Services with the department, and I am thrilled that you could join us. I do want to go over a few items prior to the training this morning. We are using a Zoom webinar today. With our presentation, please be aware that each attendee will not have use of their microphone or video as in our other Zoom meeting events. You will be able to see our presenters, however, we will not be able to see or hear you. While the presenters and I can send you a private message or information through the chat box, for this presentation, you will not be able to respond. However, if you have a question as you are listening to our presenters, please feel free to add that question to the Q&A box. We will have individuals who will be monitoring questions throughout the training, and at the end, I will pose as many of the questions related to the content and topics we are learning about today to our presenters as time permits. If you have any technical difficulties throughout the training, we have someone who is ready to help you. If you are experiencing problems or issues, Makeda Radich is your go-to person. She will be posting her email in the chat box for your convenience. For continuing education credit, the training has been approved for 3 hours for the following disciplines: nurses, social workers, mental health counselors, prevention professionals, chemical dependency counselors, and psychologists. By logging in today, we have your attendance, and we will be able to see how long you have participated in this training. If you log out early, we will adjust your certificate hours to the amount in which you participated. Please understand that we are unable to verify attendance for those who have joined the webinar by your phone, as we are unable to see the dialer's first or last name. If you're requesting continuing education, please log in with the email address with which you registered for the conference to receive continuing education credit. After the training, Courtney Ebersol will send you an email that includes a SurveyMonkey link that will allow you to evaluate this training. You must complete this evaluation in order to receive the continuing education credits. Please ensure that you provide your license number in the evaluation. After completing your evaluation through SurveyMonkey, your continuing education certificate will be emailed to you within the next 2 weeks. Please allow for some delays, but we will try to get this out as rapidly as we can. And now I'd like to turn this over to Tom Craig, who will introduce our first speaker. Tom?
Hello, everyone. I'm Tom Craig, Mental Health Director for PEGS Foundation. We're sponsoring and participating as much as we can in all of our crisis events and all of the Crisis Academy events. Ron Bruno is the Executive Director and one of the founding board members of Crisis Intervention Teams International, CIT International. And he got up bright and early because he's out in Utah today. And Ron has been involved in CIT programming for over 20 years. He has 25 years of law enforcement career and as a CIT officer. He has served in many capacities as a law enforcement officer, And his true passion, of course, is working with persons involved with the criminal justice system due to their mental illness, and he has diligently worked to reform crisis response. I met him at a global crisis response meeting last year where he spoke at Georgetown University, and he's just one of the thought leaders in crisis response work. Ron is an appointed member of the Interdepartmental Serious Mental Illness Coordinating Committee, ISMIC, and that's a committee that reports to the United States Congress to make recommendations for actions that the federal departments like SAMHSA can make to better coordinate the administration of mental health services for adults with serious mental illness and children with serious emotional disturbances. And one of the other interesting things he does also is he provides consultation to a lot of these manuals and books, and in particular, he did one on the autism spectrum disorders, which I thought was interesting. Ron developed a de-escalation training curriculum for law enforcement, community members, and mental health workers. And he's not only a policeman, he's a trainer, and he's trained over 4,000 law enforcement officers across the United States. We're looking forward to hearing Ron speak today on mobile crisis response, and we ask that if you have any questions, be sure to type them in the Q&A box. Thank you. Ron?
Well, thank you, Tom. I appreciate the opportunity to be here and talk about something that I'm very passionate about, and that is crisis response systems. So I do have a PowerPoint prepared. Let me jump into that and see if I can share my screen here real quick, and hopefully technology will make this all work smoothly. So again, I'm Ron Bruno. I am a law enforcement officer. I've got a lot of experience dealing with people who have serious and persistent mental illnesses and are involved in the criminal justice system. I'm actually retired from full-time law enforcement. I went into reserve work, and right now I'm in between departments, debating whether I want to continue my career or not. I've got a few more months. For those of you that are officers, understand that. You have a few months to make sure that you keep your license active. So that's kind of where I'm at. But I'm going to share with you today some perspectives from a law enforcement perspective, from my experiences as a law enforcement officer. And not just working the streets as a CIT officer, but also as a CIT investigator, where I had to actually do the follow-up work. Back then, we didn't have things such as mobile crisis outreach teams. That's something that came along later in my career. And so I will kind of incorporate a lot of my experiences. So crisis response systems and the role of law enforcement. Let's start from the very beginning. We hear about deinstitutionalization. And the question is, did deinstitutionalization lead to the justice involvement? Deinstitutionalization was basically when they decided that they were going to take individuals who have serious and persistent mental illness, move them out of hospitals, institutions, and treat them into the community. So did deinstitutionalization lead to justice involvement? Simple answer, yes and no. Yes and no. So let's delve into that just a little bit further. How did it all come about? Well, it was in 1955, well, actually it was in the 1950s, that the United States really started to look at individuals that had mental illness, how they were being treated in the community, or how they were being treated in the hospitals. There was also another thing that was coming along, and that was the discovery of medications that could help treat people who had serious and persistent mental illnesses. And it was decided that it would be better, instead of just to keep warehousing individuals in hospitals, to move them out into the community and treat them in the community. Treat them in the community where they're closer to their family. So Congress established a joint commission to evaluate the nation's mental health situation in 1955. In 1961, the Joint Commission recommended community health centers be established to treat those with less severe mental illness. Now, the issue that was going on at the time is there was a lot of interest in trying to define how would these centers actually work if we were to move them out into the community. Who would treat them? with those mental health centers, President John F. Kennedy signed the Community Mental Health Centers Act to develop those centers. Now realize that the United States realized that they needed to have between 1,500 to 2,500 centers. That's the plan in 1963. In 1977 though, only 650 centers were actually developed. So we did not meet the need. Now keep that in mind. We did not meet the need of what we needed to do to serve those individuals. Remember also that those centers were actually there to treat those with less severe mental illness. Instead, what happened is that we actually had, sorry about that, having technical difficulties of my own. What actually happened is that we had the people that had severe and persistent mental illness, because of Medicaid and the way that it was set up, they were actually getting sent to the hospitals. Well, once they were serving their term in the hospitals, they were then released into the community centers, and the community centers became overwhelmed with those with severe and persistent mental illness. So what did lead to the, sorry about that, technical difficulties. So what did actually lead to it? To the, what was the cause of deinstitutionalization? Well, state hospitals closed. Sent the people from the state hospitals out into the community. Funding of the community mental health centers was not sufficient and remained unstable. Even to this day, the funding kind of varies. Where are they getting their funding? It comes from Medicaid, it comes from insurance, and that is not even a stable type of funding system. The cost of psychotropic medications. We have had experiences where individuals are doing very well on a certain medication, but then for some reason, it is decided by their insurance that they need to actually change that medication, and the new medication does not actually work as well. That happens a lot with people that are incarcerated. They have a medication while they're living in the community, it's working well, they get incarcerated, the jail system or the correction facility changes their medication, which is not quite as effective, and they start to decompensate. And then when they come out, it is looked at, well, let's try the less expensive types of medications before going to the more expensive kinds. Insufficient and inconsistent case management. We realize that people that have severe and persistent mental illness that are out in the community need assistance through case management. If they have a case management component, then they are more apt to succeed in being able to live into the community. Think about that. We have individuals that have severe and persistent mental illness. We put them out into the community and we tell them, okay, we need you to have an appointment with this therapist at this location. We also need you to stop in and have an appointment with this psychologist at this location. We need to get you your med check at this location. And you also need to attend this group over here. People that have severe and persistent mental illness often do not have the ability to function at that level of being able to keep those types of schedules and being able to get across or to find transportation to get to those locations. So again, if we have case management that can deliver some of those services and help that individual maintain their schedules for treatment, they're going to be more successful. Unstable funding of community treatment teams. We know that ACT teams work. We had teams here in Utah that I dealt with, which were JDOT, Jail Diversion Outreach Teams. I can tell you numerous cases that I personally have had where individuals had involvement with the criminal justice system and kept going deeper and deeper until I was able to get them tied into a JDOT team where they would deliver the services, including case management, right to the individual out into the community. And by doing so, the person was successful. But funding was not stable. We would lose some of that funding and the JDOT teams would be reduced, and sometimes they would be eliminated because of funding issues. And then I saw those individuals again get further and further involved in the criminal justice system. Again, we need to really look as a nation on how we are going to deliver services to those that are in most need out into the community. and find the funding for that. Because if not, we end up basically being more reactive instead of proactive. We end up being more in the lines of needing crisis response systems because individuals decompensate and hit that crisis level where we have to become involved. And civil commitment criteria changed over the years, making it more stringent with an emphasis on dangerousness. Now think about that. We changed the civil commitment criteria, right or wrong, and most communities base it on dangerousness. So who do we think of when we have a situation and we're basing it on dangerousness? Law enforcement. And that's really what kind of spurred the growth of law enforcement to take on the primary responsibility of crisis response, was because of that level of dangerousness. The results for the justice system is corrections became the de facto mental health facilities. We've all heard it before. LA County Jail, Cooks County Jail, Rikers Island, the largest mental health institutes in our nation. And law enforcement became the de facto crisis responders. But we all know that. So now let's look at the crisis response systems and their models. There's basically three models: the law enforcement model, the embedded co-responder model, and the crisis intervention team model. I know people are thinking, oh, wow, but what about cahoots and these other models? They actually do all fit into these three models, and we'll talk about that. Let's look at them independently. Let's look at the pros, the challenges, and also the unintended consequences of each model. The law enforcement model. It basically starts with a call to 911. The call taker takes the call, gets the information, and delivers that information through dispatch to an officer to respond out. The officer responds out into the community, meets with the individual. If the person is escalated, hopefully has the skill set to de-escalate that situation, and then do an evaluation of whether the person meets the state criteria of danger to self or others. If the person meets that criteria, they're most often taken to an emergency room. We know, and for those of you that have lived experience that might be attending this conference, and the officers, we know that the emergency room is not necessarily the most effective way to treat a person in crisis. Why? Emergency rooms are basically set up as triage centers. It is to get a person in, to stabilize them, and get them out. It is built on a rotation basis. Get them in and out as quick as possible. And if you can't stabilize, then to get them handed off as quick as possible. However, crises generally need more time. They need to be handled at a slower pace to be able to be more effective. So that's part of the law enforcement model in most communities, not only in this country, but in most countries, is to take them to an emergency room. Or if the person doesn't meet the criteria and has committed any type of a crime, jail. And for those of you that are officers that are attending this, who have been officers for quite some time, can you ever think of a time that you actually had an individual living in the community that you were called out on? You realized that they did not meet the state criteria to be able to take them involuntarily into protective custody, but you also did not feel right leaving them where they are. You were able to identify a minor crime, and that gave you an opportunity to basically get this person to a safe location such as jail. So that is an option. Or, unfortunately, the other option, if you do not take them into protective custody, if you do not arrest them, and if they are in crises, in many communities throughout this country and others, the result is leave them there. But leave them there without any true support. What are the benefits? Initial response is cost effective. It really is, because we have cops out there. All communities have police officers. So it really does not add a lot. It adds to, the caseload of patrol, but it does not add a lot to expense in the lines of getting an officer out there to address that crisis situation. Quick response time. Again, we already have the law enforcement officers out there. If dispatch prioritizes the call, we can get officers out there generally pretty quick to deal with the person who is in crisis. Easy to implement. A few policies, a few trainings. They can even be lineup trainings because it is minimal. Basically to get the person out. The training. Notice I said it was minimal because it was minimal. And that really was a place where CIT was born. And we'll talk about that here in a second. The unintended consequences. It does not necessarily provide clinical benefits. Again, we're getting an officer to go out into the community and identify whether this person meets the state criteria to take them into protective custody to get them the help they need. But if not, basically it's one of two things in a lot of communities: jail or leave them there without any true support. Secondary aspects are expensive. Very expensive to take a person to an ER. If they do have insurance, good on them. If they don't have insurance, they could be held liable for that amount, or it is written off by the hospitals, which of course then just adds to the expense for everybody else through the insurances. So the secondary aspects of utilizing an ER to assist somebody is very expensive. It may increase stigma. In a lot of communities, if a family member has a loved one who enters crises, they call 911. Often, law enforcement is dispatched, but not only law enforcement, they also dispatch out emergency medical services. And then the streets are lined with generally 2 police cars, a lot of times a fire truck, and maybe an ambulance. And then everybody comes in, bringing unneeded attention to this family. Everybody comes in and makes the determination whether this person is going to be taken against their will, if not voluntary, to someplace. And a lot of times if they are, the fire truck and the ambulance drive away, and it is left to the law enforcement officers to take that person into custody and transport them. And that can add to a person's trauma history. I have spoken to so many individuals, or those that have spoken at our crisis or CIT academies, and shared that, you know what it's like to be in crises. And then to have law enforcement come in, and then for transportation to put you in handcuffs, and then put you in the back of a police car, and then you're taken to an ER. And in the ER, they made me undress and put on a robe. I'm just there because my mind is struggling. And I know that that's not in all hospitals, but many hospitals do have that. There's a twofold for that. One is that it's just their policy, but 2 is that there's some stigma attached. Even some hospitals believe that if a person is in crisis, they may be hiding a weapon or they may be dangerous. And so they want to take away all of their belongings to make sure that they are safe. But that all adds to a person's trauma history. If they are in deep crisis and they start to act out, if they start to, if their emotional level gets to the point of where they are thinking fight or flight, then they're strapped to generally the gurney. Again, adds to a person's trauma history. It may increase criminalization and potential use of force. Anytime a law enforcement officer goes out, they're always aware of a crime possibly being committed. Now, of course, we can, in most jurisdictions, we have, the ability to overlook the minor crimes and get the person help. It's called diversion. But in some areas, it can't be that way. Or the criminal aspects go to that level that we do need to take some type of an action. So it can increase criminalization and potential use of force. As I travel around the country and I talk to communities about crisis response systems, I always ask this question. I say, raise your hand if you've ever had a police vehicle pull behind you and turn on their overhead lights to pull you over for a minor traffic violation. Most hands raised. And then my second question is, keep your hand up if you would say that your anxiety level raised, your emotional level escalated. Most hands stay up. I'm a police officer. I can tell you that I was in an unmarked vehicle heading down, and another agency pulled me over. And I actually did feel, oh my gosh, what is he pulling me over for? I had an anxiety, a little bump in my anxiety. I mean, I don't know why. It's kind of like, I'm a cop. I was probably, I was also in special weapons and tactics at the time. I probably outgunned him even. But that action even raised mine until I was able to realize, hey, this is just a traffic stop. But that's what most people experience, is a bump in their anxiety level when we just pull them over just for a minor traffic situation. Now think if you're emotionally escalated in a mental health crisis, and now you have officers approaching you. What do you think you're going to experience? Well, you definitely are going to experience a bump in your emotional level. When I teach de-escalation training to law enforcement officers throughout the country, we discuss that. Just your mere presence of walking up to somebody is generally going to bump their emotional level up. If they're in crises, it can put them into a fight or flight mode. We need to address that and try to de-escalate that situation. But that's where the potential use of force could increase, is because we have to react to how this individual is reacting. And if an officer is not highly well trained to realize that they're dealing with somebody in crises, and highly well trained to be able to maintain their own emotional levels, a lot of times the level of force will go up. It may delay people seeking help. If you have a bad interaction this time, it may delay you from utilizing that service again. I've talked to families that said, the last thing we want to do is call the police on our loved one. So we don't, unless we really, really need to. But again, the problem is that what we're saying is, okay, we've got a system that encourages families to allow the situation to reach that crisis level where danger may come into play before they feel comfortable reaching out for the help. So, law enforcement is really good at trying to address the situations that come up and face them. And because the funding of the crisis system has not been there, law enforcement basically has had to take that position, and in that position has had to find answers. Well, the first answers was utilizing the law enforcement model. But then other models started to come around. LA introduced a model years and years ago, right about the same time that CIT was involved in the 1980s. And it's called the embedded co-responder model. The embedded co-responder model, it basically starts the same way. It's a 911 call. The 911 call then goes to dispatch. A call taker gets all of the information, hands it over to the dispatch unit. The dispatch unit then contacts law enforcement patrol unit or the special embedded co-responder model and sends them out to the crisis call. From there, a clinician and a law enforcement officer are sent out as a team in that police vehicle to go deal with the situation. Now, I still struggle to find an embedded co-responder model as a primary type of response. Most communities just do not have the funding to be able to hire enough or to have enough embedded co-responder models that they are a primary response. Meaning that there are enough that anytime a crisis call comes in that they can send out the embedded co-response. Generally, it's a secondary response where law enforcement is sent out initially, patrol is sent out initially, and then if necessary, then the embedded co-respond model can show up. That's how it is in a lot of communities. where it is a secondary response. But let's look at the pros and the cons, the benefits and the unintended consequences. The benefits: delivers mental health care to the field. It brings that clinician right into the person's home to basically help them stabilize. The same type of care that the person can receive by going to an ER in the lines of speaking with a crisis worker there can actually be delivered by this model right in the person's home. That's a big plus. It may reduce emergency department transports. Because of that clinical care that can actually be given into the field, we don't necessarily have to transport nearly as many individuals to the emergency room. It may increase linkage to community care. That is in hopes. And the reason why it says may is sometimes those clinicians are so tied in and hired by the law enforcement agency that they are separate from the community mental health services. And sometimes those linkages do not get totally connected. Sometimes it is left up to the police department to actually do all the follow-up. In other words, the special unit, the embedded co-responders, when they're not responding to some type of crisis, will then go out and deliver follow-up care. In other words, check on the person. And that's great. That's wonderful. But it doesn't necessarily, in all communities, link them to the community health services. They can be referred, but it doesn't give them that full linkage to community care. And individuals with mental illness and their families may prefer this to law enforcement only response. Absolutely. In fact, there was a study out of the UK, because the embedded co-responder model is huge in Canada and also in parts of Europe, UK. And there was a study that was out of the UK that they asked that question: do you prefer law enforcement response or do you prefer the embedded co-responder model? And the majority of families says, oh, absolutely, the embedded co-responder model. But the one question that was not asked is, would you prefer law enforcement response, the embedded co-responder model, or no law enforcement, just mental health services coming out? So that is a study that we still want to try to follow up and see if we can get that looked at to see what the response to that will be. What are the unintended consequences? Further defines mental health crisis as a law enforcement issue and expands law enforcement's role. Again, what we're doing is we're saying, if your loved one is in crisis, call 911. We will send out a law enforcement officer along with a clinician to come out and help you through this. Now, by all means, there are crisis situations that we need law enforcement to go handle. There are crisis situations that we need an embedded co-response to go out to. It is a benefit. If there's a level of danger, yes, we need to send a law enforcement officer out to go deal with that situation. And if we can, send out both law enforcement and mental health services, that is a huge benefit. But anytime a law enforcement does show up on scene, it does become a law enforcement issue. It may increase stigma and add to a person's trauma history. I just had a discussion yesterday with a community up in Toronto where the law enforcement agency is looking at uniforms. What kind of uniform should we wear in our embedded co-response? And I said, well, to be honest with you, plain clothes is probably the best. He says, well, yeah, besides that. And I says, a softer uniform. Because a fully decked out patrol officer can be intimidating. It can increase a person's emotional level. And the more militaristic that a person looks can kind of add to that. So a little softer uniform definitely does help. But it can add to the stigma that, again, we need law enforcement to handle a mental health issue. And it can add to the person's trauma history, just as in the law enforcement model. It may allow clinical interaction to be dictated by police policy. Even if the person is in partnership with that law enforcement agency, if law enforcement is responding, generally law enforcement policy is going to dictate that situation. And sometimes the policy that law enforcement sets for that clinician to interact with that individual can really add to stigma and really add to a person's trauma history. Let me give you an example. There's a law enforcement agency, major law enforcement agency in this country that has the embedded co-response model. And this is a checklist that they give out to their community members. It's a great checklist in the lines of, you know, if your loved one is in crises, this is what the information that the officers are going to ask for. This is what you should expect. And as we look at those expectations, especially this one right here, you'll see that it says, officers will detain your family member, which will include handcuffing, and is for the safety of everyone, including your family member. That is their policy. If you contact 911 in this community and say, my loved one is in crisis, they will send out a uniformed officer, a couple of uniformed officers, and they will be handcuffed. And if the embedded co-response comes out, they will not allow the clinician to deal with that person unless that person is in handcuffs. I spoke to a sergeant of this agency. Again, another policy is that if the embedded co-response model is not available to respond out, then the patrol officers will take that person in handcuffs in the back of their police vehicle, and they will take them to a local precinct. They will handcuff the person to a rail and have them wait there for the embedded co-response to show to that precinct. I think the number was about 20% that need that level of care are handled in that situation. So again, it allows the clinical interaction to be dictated by police policy in some instances. It may increase criminalization and potential use of force. The same thing as having law enforcement out on the law enforcement model. We're still introducing law enforcement into the crisis situation. But again, it's may. It's not an absolute. So these are possible unintended consequences that we have to look at. And it allows avoidance to adequately fund mental health services. And that's what's happened in a lot of our communities. It has been placed on law enforcement's back to be the crisis responders. And law enforcement finding ways to take on the challenges that are given to them, identified this embedded co-response model as a way to actually get clinical help. Instead of just sending a law enforcement officer out, getting the mental health to go out with them. It is a great idea. It is a great model in the lines of getting that mental health out there. But at the same time, all we are doing is basically, again, putting more on law enforcement and not demanding that the mental health care system become the primary responders, become the primary responsible party to deal with the crisis in our community. The last model, CIT model. Now, I can tell you that if we were in a room and I were to say, tell me what CIT is, the majority of people are going to be saying, oh, CIT, that's where they train officers how to go out and deal with situations. CIT, that's that law enforcement training. CIT, it's to train law enforcement. That's what we hear time and time again. But for anybody that is a CIT officer or anybody who knows of the CIT model, probably has heard the term by our founder, Major Sam Cochran, CIT, more than just training. And it really is. CIT begins with collaboration. Unfortunately, there has been too many communities that started CIT with training. Basically, they found out about curriculum and they think, okay, this is a law enforcement training model. So they send a couple of officers out to identify what the curriculum is. They come back and they basically get into the mode of train, 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 train. If you really want to embed CIT into your community, it starts with collaboration. It brings in the partners. It brings in law enforcement services. It brings in behavioral health services. It brings in advocacy services. It brings in people with lived experiences. It brings in the other behavioral health resources of your community. It brings in the funding streams that are possible out there. It brings in state behavioral health administration. It brings everybody together to really look at this as a whole, not just what is law enforcement going to do, but how are we going to really design a system that works for everybody? It continues with crisis system mapping. We go into a community and we identify what is the current crisis response system? What are the components of it? It looks at the best practices of crisis response and says, what can we add? How are we going to fund those? How are we going to incorporate those? So again, CIT is not so much all about law enforcement training. Now, by all means, training law enforcement, I'll talk about that in a second, is very highly important. But the whole idea behind CIT is reforming your crisis response system, finding those components that you can put in there. So let's look at the CIT model in the lines of how does it all work together in the lines of a crisis response system? Well, remember in the other two models, basically the calls go into 911. In the CIT model, we advocate that there's another step there. The calls can go into either on the one side of your screen where you see the gentleman in the blue, the Emergency Communication Center, 911. On the other side, the person with the headset, with the silver shirt, is representing a crisis line. You see that line right down the center. We can actually look at this as two separate systems. We have the justice system on this side, and we have the crisis system or the behavioral health system on the other side. We need to build a link here. First, we need to introduce into our communities to make sure that they understand that if your person is in crisis, if you're in crisis, you do not need to necessarily call 911 unless there's a level of danger. You can contact the crisis line and deal with them directly and bypass law enforcement and the criminal justice system altogether. However, we need to build a bridge between these two systems right there, so that if a call does come into 911, we train our call takers how to triage that call. I have spoken to communities and to chiefs and sheriffs about this, and many understand the concept, but I've also had chiefs and sheriffs say, oh, no, that's our responsibility. If it comes into 911, that's our responsibility. And how are you going to triage? Well, we do triage. We triage calls all the time. We then give them a priority. Which ones do we need to put at the top of the list and have officers respond out immediately? Which ones can we put down at the bottom of the list? And, when we have time for our patrol officers to go handle, we do that. We can do the same thing here. Basically develop the series of questions, and there are communities that do this. Develop the series of questions to identify, is law enforcement needed? If not, we do a warm handoff to the crisis line. A warm handoff, not a transfer, but an actual warm handoff where you contact that crisis line while that third party is on the line still, and make sure that that information gets transferred and that person gets transferred before the emergency communication center disconnects. Make sure that crisis line signs off, yes, you can disconnect. Now, crisis line services can do a secondary triage at that point. They can identify, this is a little bit more dangerous than we were planning on. So instead, we better get law enforcement back involved. So they can do a three-way back and get law enforcement services back online and then figure out the next step on how they want to respond. So what does that next step look like? Well, we're all used to the justice side, the ECC, the emergency communication side. They have access to, of course, EMS, emergency medical services, and they also have access to send out law enforcement to any situation. So those are the resources on that side of the line. On the other side of the line, hopefully there's a resource like a warm line. A warm line is generally staffed by a certified peer specialist. So many times we have people that are calling 911 that appear to be in crises. But then when we start to talk to the person, we identify, well, this really isn't such a crisis situation. This person does need to speak to somebody. And it doesn't necessarily even rise to that level that the crisis line personnel has to deal with it. That's a kind of call that can be handed down to a warm line. A person who has hopefully lived experience that can be that empathetic ear. Talk to the individual about their own experiences. Talk to the individual about what they're experiencing, what they're going through. And also offer some community resources that they can possibly handle. I've seen warm lines work so effectively where we have had continuous callers into 911. If you're a law enforcement officer and been around for a while, you could probably identify some individuals who you've gone out on numerous times, only to find out each time that really there's not much there for us to actually deal with. Well, that's a perfect person to hand off to the crisis line, to hand it down to the warm line, and have the warm line work with that individual. I've seen warm lines work where they have built up rapport that a person who is living in the community that struggles actually gets some instruction. Hey, if you're feeling this way, you can contact these individuals, but feel free to contact me anytime. My name's John, and here's the number to the warm line. And they can actually fill that niche, that need for the person in the community. Now, of course, not everything's going to be handled at the warm line. Not everything's going to be handled at the crisis line. So at that point, we would love to see a service called Mobile Crisis Outreach Team or Mobile Team, whatever you would like to name it. But it is basically a non-law enforcement community response team to go out and deal with the crises. A lot of times it is made up from a clinician and a person with lived experience, a certified peer specialist. And by the way, just from personal experience, I can tell you, certified peer specialist going out in the field on crisis is just a fantastic asset. There's been times that I have gone out as a highly trained CIT officer, and yeah, I could get it de-escalated, but I couldn't make that connection. And the clinician would try, and they couldn't make that connection. But then the certified peer specialist would start talking with the individual. The clinician and I would basically step back and just let the peer specialist handle it, and made the connection, and was able to talk the person into getting the assistance that they need. Great asset. Now, we know what Cahoots is. Cahoots is out of Oregon. Great program. Fantastic program. They have teamed a paramedic with a clinician to respond out to the community needs. That is this model. That is this model. That is that non-law enforcement. Whatever the combination is, whatever the mixture is of that mobile crisis outreach team fits right there in that box, as long as it's non-law enforcement. But now remember, the embedded co-response is a fantastic model in the lines that we have situations that are going to require law enforcement to respond. How do we deal with those situations? Well, hopefully we do have a computer that locks up. Hopefully we do have a special team of officers in patrol called CIT officers, or somebody trained like a CIT officer. Now let's talk about that for a second. CIT. Should we train everybody? Well, I think that any officer, first off, in this country, and probably in the world, would be able to identify if it's any size agency, if it's a larger agency especially, would be able to say, you know, there's times that I would not want this person to go out on a situation with me because they had escalated. I've had those types of officers that it's kind of like, I would almost rather go out by myself because otherwise they're just going to escalate the situation. That probably is not going to be a good fit to be a person who is tagged as an expert to respond to crisis response. We have found that a qualified CIT officer is somebody who has the skill set, who has the desire, and then receives that special training. And those are the ones that excel. Those are the ones that go out and do a great job. So we have a set of specially trained officers in patrol. That way it doesn't add to the expense. It's just taking a set of patrol officers that have that skill set and that desire and give them that extra training to make them the specialists, the experts in not only identifying that they're dealing with mental health issues, not only in the de-escalation skills. And by the way, the de-escalation skills, we can teach those to any officer. We can teach those to any officer. In fact, I have found personally that if we take the de-escalation and train an officer in those that does not really want to be a CIT officer, they will learn those skills. They will be more effective at learning those skills in that manner if we just unplug the de-escalation portion and give them that training than if we put them through the whole week, because a lot of times they're kicking and screaming throughout the whole week and they don't even listen to the de-escalation portion. But getting back to this, we have a specialized crew or cadre of law enforcement officers in patrol that they're handling patrol calls, but when a call for service regarding behavioral health issues arise, they are the ones that are dispatched out as first responders. So they can respond out independently and go deal with that situation and stabilize the situation, make sure that it is safe, and then to make a determination. They are the ones that are trained, highly trained into understanding all of their community resources so that they can actually talk to the individual about the resources available to them. They are the ones that understand that if they go out on a situation where the person is suicidal, but they get out there and they start talking with the individual, they learn the skills to be able to de-escalate that individual. They get that individual to understand that there is not, that there is reason to continue to live. And they are able to develop a safety plan, possibly getting a family member to come and be with that individual, where they remove the criteria of this person now being a danger to themselves or others. They can't take them into custody, protective custody then. And if the person doesn't want to voluntarily go someplace, they can build a safety plan to make sure that the person does remain safe. But another part of the training is that if your community does have a mobile crisis outreach team, is that they learn how to work as an embedded unit with that mobile crisis outreach team. That means that the same way that the embedded model has the law enforcement and the clinician working together out in the field, we can actually have that exact same model in the CIT model, because we train our CIT officers how to actually utilize those same types of partnerships, those same types of skills. They generally, because they are being sent to the majority of those types of calls, they get to know the mobile crisis outreach team by first name and how to work with them. And then they meet on scene and then they can actually work together. Another benefit of this model is that if we do have law enforcement out on the scene, if it is de-escalated and there's just going to be some clinical support given to the individual there, some stabilization given to the person inside the community, and at the same time, they are going to give them some resources and follow-up criteria, law enforcement can leave. Another benefit is how many times, for those of you that are law enforcement, have gone out to a situation and, like in the law enforcement model, have dealt with somebody. They didn't meet criteria to be able to take them into protective custody. They didn't voluntarily want to go anywhere. There was no criminal aspects, so you left them there because there was really nothing more you can do. Well, in my community, we do have mobile crisis outreach team. And I got to tell you, it is so nice for me to go out to a situation and identify that, you know, this is mental health related. And instead of leaving the person there without any resources, to be able to contact MCOT. And they can either A, respond out while I'm there, or B, many times I was able to say, well, there's no danger here. Can I have a special team come out and just visit with you this afternoon? And the person would say yes. I would call MCOT and say, hey, when you're in the area sometime today, can you swing by and talk to this person and offer them some resources, talk to them, get them some help? And they would. So again, I'm not just leaving the person in the community without any support. I am giving them that support. Now, not all crisis situations are even going to be resolved at this level. So we do need another level. We know what the level is over on this side. That is the emergency room. But we also need to build crisis response centers, dedicated crisis response centers where they utilize the living room model. I know it's becoming an old term, but the living room model. You know, when you go into an ER, so many times I've taken an individual in the ER and the first words out of their mouth is, what insurance do you have? Or you need to take off your clothes and put on this gown. But when I've taken a person to our crisis response center, basically the first words out of the mouth is, "Hi, John," as they meet the person by their first name because they knew they were coming in. "Come on in." Next words are, "Can I get you something to eat or drink?" It is a completely different model. There's no beds. Generally, it is just the lazy boys. And it's taken at a much slower pace to really deal with the person that is emotionally escalated. And it is at a more calming type of situation. It's a great resource. Now, there are smaller communities that really, it is difficult to fund crisis response centers or access centers. So there's another component called access centers. Access centers are generally part of the hospital system, even tied into the ER, but it is a separate area of the hospital where a person can actually be taken there, and it is the exact same living room model. And that's not a bad thing. A little more expensive in the lines of the rates, because they're still utilizing hospital services, but in smaller communities, it's sometimes an easier aspect than trying to stand up a crisis response center. But again, the whole idea behind a crisis response system is that a person in crisis should be handled in the least intrusive manner possible. And if that means that we can send out a clinician and certified peer specialist to deal with that person there, we should. If we can actually have that person handled by warm line, we should. If we can have that person handled by the crisis line, we should. We know that the majority of calls that go into a 911 center do not require law enforcement response. We also know that the majority of calls that go into crisis lines throughout this country are handled at that level. So that's the idea behind a CIT model. Training law enforcement, absolutely important, but that's not the whole system. What are the benefits? Reduced calls to 911. It provides opportunity for crises to be resolved telephonically. It reduces transports and taking people into protective custody. It delivers mental health care to the field and increases linkage to care. Reduces contact with the criminal justice system, criminalization, and potential use of force. Because again, we are removing law enforcement for many of the times that law enforcement is not needed. It reduces stigma and potential increase in a person's trauma history, and it encourages seeking help earlier. How much easier is it when family has crises that they contact the 911, instead of contacting 911, they contact the crisis line, and the crisis line can give them some resources right there. Or the person in crisis or the family member also realize, hey, I can have some people come out here and talk to me right here and not have to be taken somewhere. So it does encourage seeking help earlier. The challenges often requires crisis system reform and restructuring, which is a big undertaking, number one. Number two is that, yes, that does require funding. It requires that financial commitment to community crisis services, to stand up those services, to look at shifting the responsibility from criminal justice to the mental health system. CIT International last year introduced this guide. It is Crisis Intervention Team Programs, a best practice guide for transforming community response to mental health crises. You can download it free at our site, www.citinternational.org. You can also order a hard copy off of our site. And so with that, I would love to, I believe we have some time to take some questions.
Okay, let's see here. The first question, I believe, is from Diana King. And her question is it possible for hospital emergency rooms or facilities to have licensed therapists or social workers on staff to prevent some of this added drama?
Yes. Yes. Most hospitals that I've dealt with do have therapists on staff to actually address it, at least crisis workers to be able to address it. If I'm answering, if I got the question correct. So yes, they are generally tied into the ER.
Okay, thank you. Next question is from Jill Sokolnicki. Can you please explain what a JTOT team is, including if they are mental health treatment providers or law enforcement employees?
Great question. So the JDOT team that I've worked with, it's Jail Diversion Outreach Team. It's an ACT team, Assertive Community Treatment Team. And basically, it is to work with that population that has justice involvement because of behavioral health issues, mental health issues, especially where this team delivers the services that they need directly out into the community. So it's generally made up of a prescriber. It is generally made up of a case manager, a LCSW level, or possibly a master level clinician. It is made up, I mean, those are the three major components, and they don't necessarily all have to go out at the same time, and they don't even necessarily have to go out every time. In other words, they build up the relationship with the individual so they can handle a lot of stuff telephonically. And so many times that the person that might be struggling with something can just contact their case manager by phone. But the idea is that JDOT maintains that constant contact so that they are making sure that this person is meeting their therapeutic needs, meeting their living needs, and helping them progress into the community further.
Thank you. Next question is from Roxana Hawkins. And she states, the presenter stated that co-responding was usually not the primary response due to funding. If we could re-imaging public safety, which would call for the defunding of police, would there be a result in being funded for co-response as the primary response?
So basically, the question is about defunding. And I will be glad to address the defunding, because that is what defunding the police is all about. It's basically taking funding away from the budgets of the law enforcement agencies and diverting that funding to some other type of social resource. Great concept on hand, but not what I would recommend. Not just because I'm a law enforcement officer, but because of my knowledge as a law enforcement officer. You've got to take into consideration what happens if we defund police. First off, most law enforcement agencies in this country are already understaffed. For those of you that have contacted law enforcement for a non-high emergency or high priority call, probably realize that it took quite some time for law enforcement to even contact you and respond out to deal with that situation. So they are understaffed. Now, if we start talking about, if we start cutting police budgets, the most expensive part of a police budget is personnel. So that would be number one place to start cutting. And it's not that they're going to be cutting patrol, because first off, they're already understaffed. They're not going to be cutting patrol because that is called an essential service. They have to deliver the service of responding to calls for service and investigating crimes. They have to deliver those. So where would be cut? In my experience, 25 years experience, anytime that we've had budget cuts, the first place to go is civilians. Any civilians working for the agency, those positions go. The next positions that go are generally those that are considered non-essential. What would be a non-essential position? A non-essential position would be a mental health coordinator. A non-essential position would be a non-reimbursed school resource officer. Non-essential would be a community officer, a community officer personnel. In other words, an officer that basically is there to address the community needs, the disturbance house, the continuous problems, things of that nature. So those are the positions that get cut. So it could cut, if your program does have CIT programs, it could cut your CIT coordinator. Another place that's going to be cut is training. Now, we're always going to have, again, the essential trainings. We have to maintain certification, especially those that possess the highest liability, such as the physical aspects, firearms, arrest control tactics, defensive tactics. But the ones that could get cut are those extra ones, the ones that really start to look in lines of what we really want our police to be trained in, such as, sending an officer. So right now, there are so many agencies that cannot afford the time of 40 hours to send an officer to a CIT training. I guarantee you that would be one place that would be cut. Those are skills that we really want to have a cadre of that level, whether it's CIT or some other mental health training. We want that expert level, but that could be a place that it could be cut. So we start to lose that. So our recommendation is not to necessarily to fund police, but just to fund the behavioral health system that should have been funded back when we start talking about deinstitutionalization. Deinstitutionalizing was good. What was not good is that the funds that were promised did not actually follow and increase as necessary.
Thank you. Next question is from Penny Sittler. How do you flip a community from CIT being training for law enforcement to embedding it into the community?
It's a great question. So if you've already got the CIT program that is embedded as a training law enforcement program, law enforcement training, because it is not a law enforcement program, it is a community program. So the first thing to do is to actually start to stand up a steering committee. You most likely do have a CIT coordinator or somebody that is in charge of that CIT program. Seek that person out. And if they are really dedicated to CIT, they're already kind of aware of where it is. Download a free copy of the guide and go in and set up some meetings with that individual and see if you can get that individual to introduce you to the chief of police and start working with the chief of police. Start bringing in advocacy. Start to basically grab that book, go into the section that talks about how do you build the partnerships, and start right there. Even if you have CIT training is already in place, start there and say, we really want to help reduce law enforcement's requirement to being the primary responder to crisis situations. We want to help you do that. Most chiefs, especially in today's temperature, are going to welcome that kind of talk.
Thank you. Next question is from Dana King. If I contact my local police department, will they tell me which model they use?
Hopefully that the agency would definitely identify that they are involved in the model. But then you've got to do a little bit more research, because so many times we have agencies that say, oh yeah, we've got CIT. Well, that means that they're sending all of their officers to go to a 40-hour course, whether they want to be there or not, and whether they'll ever use the skills. Let me give you an example about, and I'm stepping off, sorry, and then I'll just real quick give you an example about how bad it can actually be to mandate CIT training. I was the CIT Utah program director for many years, and we had to have, because of our funding stream, we had to have evaluations from every single officer. And there, every now and then, I would get an evaluation that would say, and this is after they've passed all the testing and everything, they would say, you know what, I don't believe in mental illness. I think people are just weak. I think that if they commit a crime, they're going to jail. That's what I do as a cop. I mean, that's a bad situation developing right there. So we don't recommend training for all, but you got to dig in a little deeper. If they say that they have CIT, find out how many of your officers are trained. And if they say, oh, we're training every one of them, they don't have CIT. That's not what the CIT model is. The CIT model is a patrol-based model of specialists.
Thank you. This is from an anonymous attendee. Is there a version of a CIT that is specific to drug overdose situations, where maybe the second team member is someone in recovery and connected to the 12-step community?
So yes, that absolutely. And it just really depends on your community. So let me go to my experience here in Salt Lake County, Utah. And I was very involved in standing up our reformed crisis response system. They were separate. They were separate systems. So we had the Volunteers of America that was offering the they were running the detoxification center and those services, the substance use services. And then we had the local mental health center running the mental health system. So basically what we did is for some reason they didn't want to combine. So we had those separate ones where if we needed the substance abuse, then we would contact Volunteers of America, and they had a team identical, just like our mental health mobile crisis outreach team. And they could respond independently. They had a van that they could actually respond out independently from law enforcement. So we had two teams, one that was dedicated and the other one that wasn't. But a community could easily embed a person or a team within that mobile crisis outreach team that has those lived experiences as well, or have them as an asset that can respond out independently from the mental health team. But again, non-law enforcement, and train our CIT officers or whatever that specially trained officer is in patrol to how to work with that team as well.
Thank you. Next question is from Julie Grayson. Is there a website to download the best practice book?
Yes, www.citinternational.org, right there on the bottom of your screen. Just go to that website and you'll see a button for the guide. Click on that and it'll tell you about the guide. You can open it up and read it online. You can download a free copy, or if you do want a hard copy, you can also order one online.
And that address is also presented in the chat box. Thank you. Next question is from Kayla Fortman. Do you find a crisis stabilization center or a drop-off center similar to the living room model to be more effective?
Absolutely. Absolutely. And there's also a benefit. So first off, just the model itself is a fantastic model, especially if it's a model that is a no wrong door type model. And they're not all that way. Here in Salt Lake County, we don't even have that ability. We have to actually decide on the street which door we want to send them to. I wish we had that. But Tucson, Arizona, they, of course, if anybody's been in the crisis response systems or programming, knows about that model down there. It's a no wrong door, regardless what the needs are of that individual. Basically, they can show up there, or if law enforcement is taking them in protective custody, they can deliver them there, and that they will address the needs of that individual, whether it's substance use, mental health issues, or something else.
Thank
you.
You.
I do recommend that.
A second question from Julie. Have you seen any communities utilize community health workers as a part of the CIT? And if so, which ones?
So when we talk about mental health workers as part of the crisis intervention team, that becomes a different model. That's not actually the CIT model. That would become more of the embedded co-responder model. So remember, we do have the three models in this world. And the United States is about mixed, well, I mean, still the majority is law enforcement model. And then it is really mixed in this country between CIT model and embedded co-response model. And unfortunately, even a lot of those that claim that they're CIT model are more of an embedded co-response model.
Thank you. A second question from Kayla. We have implemented the Law Enforcement Assisted Diversion LEAD program. Is this similar to the model that you have discussed?
So it just depends how LEAD is actually rolled out. There are teams such as up in Seattle where they do pair up a clinician and a law enforcement officer that goes out, but they are strictly utilized in that model up there. They are strictly utilized as a street team where they go out and just basically very proactive in lines of trying to address some needs. LEAD can be delivered one of two ways. It can be delivered as an embedded co-response model, but it also can be delivered more into the CIT model, where the mental health or the substance use teams are separate, but can co-respond with highly trained CIT patrol officers when necessary. or that the CIT patrol officers go out, they identify that this is a person that could possibly be diverted, and then can connect them with the lead team, the mental health or substance use team.
Thank you. Next question is from Kelly Smith. How do you see the new 988 line helping with crisis response once it becomes available?
Well, first off, I mean, it's well overdue. We need something simple, something that we can basically tell everybody in the entire country, hey, if you're in crisis, contact this number. And then it just, I mean, it's still going to need some refining, of course. I mean, we need to roll it out. We need to refine it. We need to make sure that we are making the connections. My philosophy is the closer we can deliver the crisis line services to the community, the better. So if we do have that ability to try to make sure that we're not just keeping everything, as far away as possible, but we are moving it more closely to the community, because my personal experience is that it works a lot better if we keep crisis line services outside of police. So if we can utilize the resources such as mobile crisis outreach teams and warm lines inside that crisis line, that if something does go into a national bank, if it doesn't automatically just divert through 988 to the local, that it will actually, it can be handled at a closer level. So it's a great system. We're excited to see that roll out.
Thank you. Our next question is from Beth Kuchak. Can you describe how CIT model works with youth?
Yeah, basically the CIT officer is trained in youth response, and I'll get into a little bit more detail. So as far as crises, we train our CIT officers. There is a component in the training that talks about children and adolescents issues and how to deal with children and adolescents. There's generally a scenario or two that are dedicated to dealing with youth in the CIT week-long training. But it's more on the community side. So again, if you're following the CIT model, then the next step is, how are the youth handled on the behavioral health side? Here in Salt Lake County, we have a youth team that is out of the Children's Center, and basically they respond out if it is a youth to go deal with those situations and help the family. Now, NAMI years and years ago put together a program called CIT for Youth, and it is an implementation guide on how to develop CIT for Youth. I was very involved in the development of that. And when I implemented CIT for Youth in the state of Utah, it was a little different. How we did it is incorporated in that manual, but there's a couple of different ways to implement CIT for Youth in that manual. But let me share with what our perspective is in Utah. Is I would not introduce CIT for Youth training into any community in the state of Utah until there was a memorandum of agreement signed by the law enforcement agency that is over the school districts, the school district itself, and the behavioral health services in that community. And that basically it is a requirement that the memorandum of agreement says that each of those disciplines are going to identify a person who will be represented on the crisis team. And as a whole, the crisis, those individuals work with behavioral health services, law enforcement services, the school, the youth, and the parents to come up with a plan on how they're going to address the needs of that child. And if there is a crisis plan that is developed, that crisis plan, a copy of that crisis plan, is also given to dispatch of that local law enforcement agency. And the reason is that way, if a CIT officer, and we would train all CIT officers in that community, if a CIT officer goes out handling a crisis situation involving a youth, they could contact their dispatch and say, do we have any type of crisis plan on this individual? Dispatch would be able to pull that information up, give that to the officer, or they could pull it up on their mobile data terminal inside their police car and actually see what the plan is. That if the child is doing this, this is what needs to happen. If the child is doing this, the parent should be doing this. We could verify that. And we'd also have the contact information for the support team for that youth.
Thank you. The next question is a three-part question, and I'll give you one at a time. And it's from Lisa, I believe, Pori. With CIT being a community-led intervention, if a social worker or counselor is interested in working in this environment, how can locations with CIT programs be located?
How can they be located?
Yes.
So the best way on that, first off, you can contact CIT International. We do have, on our website, we do have a map of state leaders, and see if there is identified a state leader there. The state leader would, of course, state programs would, of course, have a list of every program that they have inside their state. So that's the number one way to do it. Of course, your state has a center, so I would just contact the center and they would be able to tell you. If you're calling from outside your state, then yeah, just contact us and we'll see if we can get you the contact information for the state unit.
Thank you. Within that answer, you did answer her second question, so I'll move on to the third. Are clinicians with CIT employed through the law enforcement agency or the local mental health centers?
So again, it is not an asset of law enforcement. So that's more of the embedded co-response model. And in the embedded co-response model, it is mixed. In some situations, they are actually employees of the law enforcement agency. In others, they are in a partnership with law enforcement agencies. So they are a paid employee of the mental health services of that community, and they are assigned to work with that law enforcement agency. But that is not a CIT model, that is an embedded co-response model. The CIT model would put that individual, they are an asset of the behavioral health services, the behavioral health care system. And they work independently of law enforcement, yet they do have the training and the ability to co-respond, meaning not jump in the police car and go with them, but to co-respond, meet out at the location if necessary, and work with those law enforcement or the CIT officers in addressing the behavioral health needs of the person in the community.
Thank you.
I hope that makes sense.
Thank you. This is from an anonymous attendee. There's a big push to get social workers and counselors to respond to mental health calls in the community instead of police. However, the most deadly calls for the police are domestic violent, disturbing calls, which may have proposed that counselors and social workers respond to. Is this a good idea to send just a paramedic and a counselor to a domestic call?
I saw that, I can't remember, there was a community that made that recommendation, and I can't remember which community it was. I can tell you through my experience, absolutely not. I have not actually addressed that with my board of directors, but I do have a board that is made up of a lot of law enforcement as well. And I would venture to say that our position, if we did come out with a solid position from CIT International, would be no, not to send non-law enforcement to domestic situations. You've got to remember is that the domestic situations are sometimes rated as some of the more dangerous calls for even law enforcement officers to go on, because we are dealing with two individuals that are emotionally escalated many times, and not necessarily are we a lot of times that when law enforcement goes out, we become the center of that aggression and that anger and those high emotions. Or it's aimed at us, I should say. So no, and let me just kind of follow up with that with, just a little bit of information is that, again, we want to send law enforcement out to those types of situations, but many domestic situations turn out to be mental health situations. And we send out, our officers, they identify that this is mental health needs, then they could reach out to the mental health system and have a mobile crisis outreach team come out and address those needs. So there's going to be a lot of times we don't know that it's mental health and we get sent out, and that's when we identify that it's mental health. Well, again, we want the resource to be able to contact the mobile crisis outreach team to come out and handle it if it's appropriate.
Thank you. We are about running out of time for questions. There are still several left. We will make sure for those who have asked questions, we will get them to our presenter so that they can provide a full answer for you. We probably have about, a dozen, maybe a little bit more left, but we really want to keep on schedule with our next presenter. I want to thank you, sir, for your presentation and your willingness to come and join us. And thank you for answering all of the questions of our participants. We appreciate you, and it was an excellent presentation.
Excellent. Thank you again for the opportunity. I appreciate it. My contact information is on the screen still. If you haven't copied it down, please do so. And I'd be glad to answer any questions offline.
Thank you very much. I want to turn this over to Alicia Clark to introduce our second speaker. Alicia?
Thank you, Joyce, and thank you, Ron, for that wealth of information and knowledge that you brought to Ohio. It's sometimes difficult in virtual learning platforms because you probably can't see that you would be getting a standing ovation at this point and hearing the applause from the crowd. So we want to make sure that you understand how important it was for us to hear those three models, specifically from a law enforcement lens. I think that was an important aspect of the presentation. So thank you. Ron's presentation will be uploaded to our webpage. So anyone who wants to reflect back on that presentation will have a chance to. And now we're transitioning to the second presentation in our agenda. And as we know, mobile crisis is such a critical element of the crisis continuum. We always say at the department that mobile crisis is the conduit that gets individuals from crisis to care and meets families where they are and provides a rescue for the families. And so ensuring that you have a crisis continuum that includes not only adults, but the youth as well, is important to making sure that we are providing responses to our community and family members as necessary. So mobile response stabilization services are on-demand crisis intervention services in any setting in which behavioral health crisis is occurring. So that could be your school system, your home, or emergency departments. And we have an expert with us, Elizabeth Manley, that I'd like to introduce. Elizabeth is the clinical instructor for Health and Behavioral Health Policy Institute for Innovation and Implementation. Elizabeth is a clinical instructor for Health and Behavioral Health Policy at the Institute for Innovation and Implementation. In this capacity, Ms. Manley provides technical assistance to states and communities specific to children's behavioral health innovations, with a specific focus on policy, financing, and development of service array within a system of care. Ms. Manley is the former Assistant Commissioner for New Jersey's Children's System of Care. In this capacity, Ms. Manley led transformation and implementation of system innovations, including integrating individuals with developmental intellectual disabilities, substance use, and integration of physical health into the children's system of care. She had direct oversight of the statewide child behavioral health, substance use and development, intellectual disability systems. This includes a wide range of community-based services and residential interventions. Prior to joining DCF, Ms. Manley was the CEO of Caring Partners of Morris Suits Incorporated, a care management organization specializing in working with youth with complex behavioral health challenges. Ms. Manley worked for Capital County Children's Collaboration, the Mercer County CMO, as the Director of Operation at the time of its inception since 2002. So let's welcome Ms. Manley with us. Elizabeth, are you ready?
I am. Thank you very much. It's good to be here today. And to talk about one of my favorite topics. So I'm going to talk about children and what's different, right? And what's the same when we're building or thinking about what the systems need to look like in order to address the needs of children and families. In 2018, the Institute actually published a paper for the National Association for the State Mental Health Program Directors called Making the Case for a Comprehensive Children's Continuum of Care. And part of that conversation was driven by the adult models of care that were coming out that are really so important in addressing the community needs and how important it is to address adults and have supports and services for adults with mental health challenges. But the challenge was that children don't respond in the same way. Families don't respond in the same way. And even in some of the places in this country in which some of the best adult models are happening, they're not impacting children in the way that we were hopeful for. And so we really sat down and thought about what works and what doesn't work. So today I'm going to talk a little bit about that work, why we came together to do that work and put that paper together, which I'm happy to share. It's also tagged as one of the resources in this discussion today. I'm also going to talk a little bit about some of the mobile response and stabilization work that has happened through the Institute over the last 5, actually probably 6 years at this point, and what some of those conclusions are, and give you a little bit of history about what happens in New Jersey, which for most perspectives, New Jersey is the most advanced system of care in the country. So let's start there. Okay, so today I'm actually representing the TA network, so SAMHSA is supporting this particular work, and I just wanted to tag that and get started. So let's start at the beginning. Crisis continuum care means that we really want to begin to think about what happens for children at the beginning. And I want to make a really important point here. For most children who were touching on services and supports within the system, this is the very first touch on the behavioral health system. The very first time that a parent is going to reach out for help, that a teacher is going to recognize that something's happening, that there's going to be some reach to the public mental health system for support and services. And so that first touch is so critically important to what happens in the future, right? It's the beginning part of how we train and help parents think about when and how to access support and care for their child. So we really want to make sure that the continuum is designed in a way that is responsive to what's happening for that parent who's also escalated. For those of you who are listening today who are parents, I think you probably recognize that when your child is experiencing something, anything, right? Some reaction to COVID-19 as an example, or, they have a cold, or they fell and they hurt their knee, or whatever it is, right? We are very connected what happens to our children. When a child begins to change and demonstrate changes in their behavior, it's really important that we're attentive to what happens to and what the experience is for families, right? For parents in particular, for caregivers in particular, and then for the extended family who tend to push away when children have pretty complex behavioral needs. And if we can get there quickly and we can actually be responsive, we can change the trajectory, not just in that particular crisis situation, but over the course of that child's experience. And really important to think about. So the crisis continuum needs to specifically design to meet the needs of children, youth, and young adults, their parents and their caregivers. We can't leave them out. They have to be part of this conversation. And it's necessary to de-escalate what's happening for the child, but what's also happening for the parent, right? What's going on for them that has gotten them to the point where they picked up the phone and called and asked for assistance. And in order to do that, we really need to be thoughtful about engagement strategies. We need to think about how do we respond when that first call happens? Because if we do this and say, I'm sorry, I can't help you, you have to call somebody else, then we've already lost that parent, and not just in the short term. It will be multiple escalations for that child before we get another opportunity to engage. And I just want to make sure that people are really understanding of that. We want to talk about a key shift to overuse of services at the highest intensities, like emergency departments, inpatient care. We want to talk about residential interventions that include both in-state and out-of-state residential for children. We want to talk about the impact of those services and supports that happen for children. We also want to talk about the use and overuse of things like partial hospitalization, partial care programs, and the underutilization of community supports and services. So I just want to put that on the table as well, because we really want to shift away from the use of those higher and more expensive services. And when we can do that, we're not just talking about the short term of what that means for that child. We're talking about the duration of their lifetime, right? So what happens for a 5-year-old who in our old days in New Jersey might have ended up in the state hospital, today would stay in their home, stay in their school, stay in their community, probably would not even engage in outpatient care until we really saw that service as being beneficial, and in the long term would more likely graduate from high school, not be on Social Security, not be touching on the adult mental health system. So we really want to think about the impact of putting services and supports where they need to be, and how we're going to engage both the family and the community in this conversation. We also just want to make sure that, and I want to make sure that I have clarity around the idea that our partners in this work are more extensive than they are in some ways in the adult world, because the partners include not just the parent caregivers, but they include all of the family members that we want to bring to the table. We want to talk about the school, the teacher, but also the coaches and the crossing guards and the school bus drivers who are important in the conversation. We want to talk about pediatricians and their role in this work. And we want to talk about all the extracurricular activities that children are engaged in, or the goal for us to get them engaged in those extracurricular activities. So as you can see, the team is a large team that's working to solve some of these challenges. I also want to argue that if you are calling the police, then we've gotten there way too late in the conversation. We've already missed about 4 to 5 opportunities of engagement with families if the first call is to the police department. So that's the intro of where we are and what we're going to talk about today. Okay, so we want to talk about diverting from unnecessary emergency department visits. I want to just say that it's really, you know, it can be very traumatizing for adults to enter an emergency department. Imagine what it feels like for a 5-year-old, a 6-year-old, a 7-year-old, an 8-year-old, a 9-year-old. And mobile response and stabilization, one of the services we're going to talk about today, is an incredibly effective intervention for these little guys, but also an effective intervention for the 18, 19, 20, and 21-year-olds as well. We want to institute evidence-based home and community-based services to provide meaningful alternatives to inpatient and residential care. That includes intensive in-home behavioral health services, which you already have in Ohio with some evidence behind them, which is really exciting. And I know that you're doing a tremendous amount of work around mobile response and stabilization, but it also includes the use of peer support, both youth peer support as well as parent peer support. And it includes the use of intensive care coordination, specifically using wraparound visits practice model. And we really want to think about the most important part of the systemic care work is addressing the parent's sense of urgency. What we have learned in this work, and I've been in this work really for well over 20 years. New Jersey started systemic care in 2000 with a pretty well thought out concept paper, and has demonstrated success year after year after year in the 20 years. Some setbacks, lots of hard work, but really has demonstrated why systemic care, a thoughtful systemic care, can be impactful across systems. So anyway, in the building of the systemic care primer, which is, you know, is where a lot of this work comes from Sheila Pyries, really thinks about and talks about the parent sense of urgency. Because what drove some of the children ending up in the highest intensities of services, like hospitals and residential, is what parents are experiencing. Now, by the time they hit an emergency department, a parent has watched their child demonstrate significant changes for sometimes up to 2 years before they get the help that is necessary and needed for them. The parent has talked to teachers, the parent has talked to other parents, the parent has talked to pediatricians, the parent has talked to community members. Something's going on with my child. As an example, and I've heard this many times in my career, you know, my 15-year-old won't get off the sofa and I just don't know what to do about it. And it's unusual for them. So my first question would be, so was your 15-year-old always on the sofa, or is this something new for them? And changes, subtle changes around grades, around eating, around sleeping are important things for us to worry about. If we use a service and like mobile response and stabilization to address those concerns and that sense of urgency for the parent, then we have gone a long way of keeping a child out of the most high intensities of service. So I just supporting that parent. We've also reduced the time, that 2-year period of time, if we're doing this work effectively, from 2 years of that parent worrying and getting tired over the worry, by the way, to a very short period of time if we do it well and we think about where we're going to put those resources and how we're going to talk to people about those resources. We can reduce that time to 1 month. What a big difference in the life of that parent and that child. So pediatric psychiatric emergency department visits nationwide has increased over time. In fact, I talked to a couple states over the last couple of weeks about how they're seeing this rapid increase right now and looking to implement services like mobile response to begin to think about this work. The emergency department usage rates for publicly insured children and children without any health insurance are 4-fold above what they are for private insured children. But I'm going to also say that is not true when your public mental health system is focused specifically on other alternatives, such as intensive in-home services, mobile response and stabilization. Emergency departments lack the expertise. You heard Bruno talk about that, really important. That's not different for children. It's exactly the same. There's not that level of expertise. Emergency departments are designed for triage. That's what they do. They're not designed to really address the traumatic experience that a child is experiencing when they enter that emergency department, or to address the traumatic experience for the parent and caregiver. They're very expensive, and we're not getting what we need. The assessments that come out there out of an emergency department are not really helpful and don't tell us whether or not there's a level of dangerousness for that child in terms of returning to school, as an example. In New Jersey, we had a lot of schools that were sending children to emergency departments for the sole purpose of trying to figure out whether or not they could return to school. It was the most ineffective and very expensive and traumatizing way of dealing with children who have demonstrated some challenges. So better outcomes are both quality of care. We really want that they're achievable through these community-based services and supports. They redefine the meaning of crisis, which I'm going to talk about because I think it's really important for us to understand language, and address and stabilize behaviors prior to escalation to the level of requiring inpatient care. In other words, it is important for us to be attentive to parents when they're feeling that there is a sense of urgency, and get them what they need at the time they need it for the duration that they need it. And let's redefine crisis from what the system or professionals, and I always say when I was a professional on the ground in New Jersey, my sense of what a crisis was very different than how parents and young people define crisis for themselves. And so when you listen to what parents are saying and hear that their 15-year-old being on the sofa is a crisis for them, that we actually are attentive to what that means and provide the supports they need at the time they need it for the duration. So a crisis, a comprehensive crisis continuum includes screening and assessment, which is really important that we use a common assessment tool across the full state whenever possible, so that you have a really good understanding of who's who and what they need in the system. We need a validated screening tool. I'm not grounded in what tool it is. There are plenty of really good tools to use. New Jersey uses the CANS, which I think has been an exceptional tool for New Jersey. New Jersey is a pretty unique place, but it's important to use one tool. We want to use mobile response and stabilization. Crisis is in here. I'm going to take it out for a minute because it's just really important that we talk about where it fits and when it doesn't fit. Okay, so mobile crisis response is in the Medicaid language. It's in the CMS world. You can get reimbursement for it. It's supported through SAMHSA and CMS in a joint letter to the Children's Behavioral Health Directors that was sent to the Children's Behavioral Health Directors in 2013. that recognizes that mobile crisis response should be a tool within the Medicaid packet of services available to families. We took it out of our work in New Jersey because it's confusing to parents. Parents and professionals believe that crisis meant that children had to be at the level of risk to be admitted into an inpatient unit. And I'm going to tell you how important it is to change that language. Because when we changed that language and helped our child protection and permanency, our child welfare system, when we helped them understand what that language meant, we were able to help stabilize children in foster care pretty dramatically, which I'll tell you a little bit about. In 2015, we did a pilot for children going into foster care, in which we put mobile response and stabilization as part of every child going into foster care because of the removal itself, recognizing the potential of the trauma experienced by a child who's removed from their home and placed in a foster home. We put mobile response and stabilization in as the first step. During that time, we asked our mobile response workers to have a simple conversation with the child that basically said, something big just happened to you. Because something big just happened to you, you might have a hard time eating, sleeping, paying attention. School might feel different. Happens to some kids, doesn't happen to all, but if it happens to you, we know what to do and we'll be right here to help you. You turn around to foster parents and say the same exact thing. Something big just happened to this child. Because something big just happened to this child, they might have a hard time eating, sleeping, paying attention. School might feel different. Happens to some, doesn't happen to all, but if it happens to this child, we know what to do and we'll help you through that. That simple conversation allowed us to reduce the number of average moves for each child in foster care from 6 to 0. 46 out of 46 children who entered foster care in that pilot stayed in the first bed that they went into, the first foster home, and had 0 moves due to the behavior of the child. Pretty dramatic of what happens for a child over their lifetime. So just something to keep in mind as we talk about this. And why language is important. The child welfare system thought that the mobile response and stabilization teams could not be helpful unless the child was at risk of admission into an inpatient unit. And that was not true, not in our criteria, not in the way we described it for Medicaid, not in our billing, not in our criteria. Nowhere did it say that that was true. Just taking the word crisis out of the title was just so impactful to our partners. And so something to keep in mind. You want to include things like you want access to psychiatric consultation. I'll just give you one other data point for New Jersey, and that's saying that New Jersey has the lowest rate of children in foster care who are on psychotropic medication. Medication is one tool in your toolbox. You want a broad array of tools that you can use before you ever touch on the issue of medication. And you want to make sure that there are referrals with warm handoffs and touches so that there is no one that gets lost in this. I just want to remind you one more time that this is the first touch that families have on the system, right? First time, it's got to get it right. And if we don't get it right, we need to actually understand what we got wrong, reapproach families and let them know what we got wrong and how we're going to get it right the next time. I talked about the SAMHSA letter, the joint letter, which is really important because it puts out a pretty broad service array that is necessary for children in order to meet the needs of children with complex behavioral health needs. I'll argue that that children with moderate behavioral health needs can benefit from some of those services. And to be honest with you, so can children with intellectual and developmental disabilities and things like autism. The federal guidance, we talked about, you've heard about ISMEC. There was some discussion in the last presentation around that. I'm not going to dwell too much on it, just to say that the attention to crisis services for children is just really important, and really important that they're defined differently, because adult models of care are not as successful. They're just not. You can see it in the data in those systems that only invest in addressing the crisis for adults. And the primary reason that's true are twofold. One, Adult crisis systems tend to get there later, and that makes sense in the adult world for a ton of reasons. Most importantly, they're adults. And two, you have parents and caregivers who are really important partners in this work, and how they define the crisis is essential on how the work happens moving forward. So why mobile response in this crisis continuum, right? I think it's just really important to say mobile response and stabilization as a service is a game changer. If I only had to do one thing in the crisis continuum, I would do mobile response and stabilization. Now, I think you need all of the other tools in that crisis continuum. And I do think you need a fully developed crisis continuum of care. But if you only can do one, or you can only start in one place, start with mobile, because it changes the way children and parents and caregivers and those teams feel about that child's behavior right from the start. Changes the way schools think about this work, changes the way pediatricians feel, changes the way police officers feel when they come across a 10-year-old who they don't really know what to do with, but they know the 10-year-old needs some help. So it's just really important that we think about mobile response as an upstream intervention and not necessarily a crisis service in the way that most people think about or define crisis. It is a crisis service because the person who's in crisis is the parent, caregiver, and the child themselves in a crisis in which we have to figure out what's driving that feeling for them, right? That experience for them. What's the underlying issues that are driving those individuals to pick up the phone and say, I need help, and I need help now. And we also want to train those folks to understand that the system is responsive. I'll give you a really quick understanding what that means. In 2012, I was brand new as the Assistant Commissioner in New Jersey's Children's System of Care, and the governor had made the decision to integrate youth with intellectual and developmental disabilities into the system of care, which was a really big project. And I learned on my first day that this was going to be a really big project for me. And we learned that we were not ready. We did not have any of the tools that we had in our toolbox for children with serious emotion, with serious and complex challenges. But we needed to be ready. I had 3 months to get people ready. And what we had in our toolbox was mobile response and stabilization. They weren't well-trained in working with nonverbal kids who have autism or children with intellectual and developmental disabilities, but they were incredibly well-trained at listening, at being responsive, of being helpful to parents in figuring out what the underlying challenges are, in looking at the environment and the communication tools. So they really did have great skills in helping us figure out how it is that we could best meet the needs of children with intellectual and developmental disabilities. And then we continue to help them grow and become better and better and better at their interventions. But mobile response and stabilization is a powerful, important upstream intervention that allows you to begin to change all the other ways in which we think about children with behavioral health needs. It also allows us to make sure that we are culturally and linguistically competent. And what I mean by that is we're not just able to speak the particular languages that families speak. And I come from one of the most diverse states in the country. At any given day, we needed to have a workforce that could speak about 200 languages. It's complicated to build that, and we didn't always get it right, but we always worked to get it right. But we also train folks, all of the workforce, around that cultural and linguistic competency is also understanding the culture of the home and the differences between how children see themselves and see their own identity versus how parents see themselves and their child and their identity, and how important those things were in really understanding some of the dynamics in the home. So when I talk about cultural and linguistic competence, I'm talking about the big picture of what happens for children and families, and not just this issue of how do we speak language. Okay, so the value within within mobile response and stabilization is just really kind of used, right? We can effectively de-escalate crisis situations that families are experiencing. We can improve their outcomes dramatically. In fact, I just looked this morning, New Jersey's success rate in keeping children at home in June 2020 was 98%. Now you might think, okay, that's because of COVID, but the truth is that it has varied from 96 to 98% for about 20 years, which I'll show you some data in a minute about that. It's designed to intercede upstream, right? Really before those things become habits, before there's anger and animosity, before parents are so tired. All of those things are really important. It's instrumental in averting unnecessary emergency department visits, and in the world of COVID, this becomes really important. It changes the trajectory around residential interventions and reduces the number of children who require them. It also helps in terms of length of stay for the children who do go or do need a residential intervention. And it reduces your costs and allow you to shift money from your highest intensities of service to your more community-based services. You can keep children safe at home, including children who have an active plan for they're actively experiencing suicidal ideation. The safest place for them is at home, but at home with a team and a well-planned team. Mobile response teams can actually figure that out for you and help you organize some of that work. It's a viable alternative to acute care and residential treatment because they consistently demonstrate cost savings, which is really, really important in this work. But the cost savings are not just on that one experience. They're really on the experience of the family as a whole. And I'll give you some examples, not from New Jersey, but from other places, including Connecticut, that's done some really important work around what mobile response and stabilization has done there in terms of really cutting the cost of inpatient and emergency department visits. The Connecticut, this particular report is actually, I think there's a link to it at the end. It's a great report to read about how do you move away from the use of emergency departments. It's just really, really powerful and impactful. And Connecticut had a different problem than New Jersey and addressed it a little bit differently, but used some of the same tools, including 24-hour access to mobile response and stabilization. King County, Washington, which has been involved in this work for a long time, really shifted some of their trajectory for children over a long period of time, and worth taking a look at their work, as well as a couple of other states to take a look at, include Oklahoma and include Nevada, who are both relatively short time in doing this work around mobile response and stabilization, but they're beginning to see big gains in their investment. These are just a couple of other examples that I think are important to take a look at. So you can see that it's not just in New Jersey, but it's really in the places that have invested upfront in making sure that children get their needs met in a way that is different than adults. So here are the components that are really important to think about, right? A single point of access and a no wrong door, which are two different but important concepts. Single point of access means that everybody knows who to call, right? They know with a single number. In New Jersey, any parent can call a 1-877 number 24 hours a day, 7 days a week, and we will send help. That is the access point for all behavioral health services for children, whether they're involved in the child welfare system, the juvenile justice system, whether they're, got in trouble at school, no matter what parent is, it's available to any parent 24/7. No wrong door means that every single partner, every partner knows how to access services for children. Some states are not able to build a single point of access, but they are able to ensure that there's no wrong door. No matter where the child arrives, they are always pointed to the right thing. That means mobile response and stabilization, the first point in the crisis continuum of care. Crisis hotlines are really helpful and important tools within the work. The electronic health record I was very fortunate in New Jersey to have an electronic health record that followed the child from the second that the parent reached out for help all the way through their behavioral health need experience. That included a ton and wealth of information, including real-time Medicaid data and all kinds of other stuff. If you can get an electronic health record that connects to other services, it's really helpful to do some advocacy around that. And that's really important in a statewide capacity because children move. I don't know how they do in Ohio, but children in New Jersey would move from one county to another, from one place to another, and being able to track and make sure that children got what they needed as they move from one place to another is just really important in terms of this work. Mobile response and stabilization, that upstream intervention is really, really important part of the component. As I've already said, I'm a fan, and I think that it's the most essential game-changing service that any state or community can implement. But you need a single assessment tool that you're going to assess children across their full continuum of behavioral health supports. Just really important to think about that. You want to make sure that people are really trained in good crisis intervention and initial identification. One of the biggest challenges I think that happens for children is they're overdiagnosed with the wrong diagnosis from the start, and it takes years to fix that. As somebody who has worked in the behavioral health system in New Jersey for well over 30 years, I can tell you that that's what happens when they end up in emergency departments, when they end up in inpatient units, because those short stays are medically focused. There's a diagnosis that's put on the table that may seem right at the moment, but often takes years to correct. So you want that diagnosis to take place over time, to have really good thoughtfulness around it, to not just have the professionals around the table thinking about it, to have your full team of people that we talked about already. Parents, caregivers, teachers, extended family are important in that conversation as well, whenever possible. Stabilization services mean that we're really working to connect children back to what's important. And if they haven't had community connections, that's where we start. We start with those community connections. I'll give you a quick example. I worked with a 14-year-old in New Jersey early on in the building of the system of care who had gotten kicked off the football team. Got kicked off the football team because his behaviors were, he did something that the coach didn't like. But football meant the world to him. He thought it meant the world to his family, and that he had disappointed them for a long time. Got very depressed, was admitted into an inpatient unit. He was given psychotropic medications and sent to a partial care program, and I ran the partial care program. During that partial care program, because we were bringing in system care and system care values, we were actually able to use mobile response and stabilization to prevent him from going to another inpatient stay, and then to put a team together around the table to talk about what was going on for him. I was at the table because I was ready to advocate that he should be in partial care more frequently, not less. He was there 2 days a week, and I was pushing for 5. And when we left that conversation, we recognized that really he needed to be playing football, and that the advocacy of the team needed to be with the coach on getting him back on the football team. But we also recognized that if he couldn't be on the football team, his extended family, who all stepped up to be part of this conversation, recognized that they needed to help him work through that loss of not being able to play football. Really dramatic. 0 days of partial care, returned to school, graduated from high school, and went on to college. Really important part. He's actually doing pretty well today. He connected with me on LinkedIn, and this is about 20 years ago. So we're really able to see the impact of these services over time. Residential crisis stabilization has a short-term, community-based, trauma-informed programs that allow for children to get a moment to breathe. As an example, they might be helpful for a child who has a failed adoption, as an example, or has had some movement from foster care, or may need some medication adjustments. Those type of things could be really helpful. Or they're new to the system and you're trying to figure out what services and supports could be helpful for them. And then recovery and reintegration means that we get children back where they need to go. A couple of really quick things around mobile response core elements. crisis is defined by the caller. Doesn't matter what they say. They can say their child won't get off the sofa. They can say their child is throwing things. They can say their child is whatever, kicked out of school. Parent defines the crisis, we go. We don't ask questions. It's not debatable. Parent says, I need help, you go. In most states, that's within an hour. In Connecticut, because they're smaller, it's 20 minutes. Services are available 24/7. If you can't make them available 24/7 in the beginning, there are some options, but really you want parents to recognize the value of the service and that there's an attentiveness to what they're saying is important. They serve children in their own homes, in their own communities, in their own schools, and they make those connections work within those places. They include a workforce that is very well trained. In New Jersey, they use bachelor's prepared people because we didn't have enough clinicians, but they're very well trained and supported and supervised as part of the way that we built the system to work. And we build them on the natural supports, right, in the communities, really important places to think about this work. Some strategies for coordination is the co-location. So some mobile response teams actually sit or share space with peer support teams in New Jersey. The use of the crisis text line, which I know Ohio has access to, warm lines and suicide hotlines. You want to be connected to all of those. And you want to use paraprofessionals whenever possible to be part of the coordination. You want to connect with primary and psychiatric care providers. You want primary care physicians, pediatricians to know who you are and to be able to reach out when they don't know what to do, right? So they want to connect. You want to be able to connect them. You want child welfare to use mobile response and stabilization rather than using emergency departments and inpatient care. You want to support children going into foster care and making sure that they feel welcomed and supported as they are experiencing these traumatic events. You want law enforcement to know what to do with children. What you don't want law enforcement to do is put cuffs on a child ever. You want them to help pick up the phone, give the information to the parent, be on the phone with the parent. You want them to do all of those things. What you don't want them to do is put handcuffs on a child. That's a traumatic experience that lasts a lifetime. You want the schools to be big partners in the work, and you'll see in the data that I share in a minute that the schools play a really important role. And during COVID-19, it's exceptionally challenging for schools in some of this work and for the mobile response teams. They are working to coordinate because they have these good partnerships in most states in which the schools and the mobile response teams are talking so that they know what children are most concerned about. We're beginning to see some of the numbers begin to rise again around mobile response, and that's actually a positive thing. You want a connection to the emergency departments. You want emergency departments to say, you know what, you don't really need to be here. Let's call mobile response and stabilization. They can meet us here, or they can, you can take your child home and they'll meet you at your home. You want the juvenile justice system to use mobile response and stabilization, to be aware of it, to be part of it, and you want family courts to be very connected to the idea of mobile response and stabilization. And then every community organization within your community should be aware of how mobile can be helpful. Some strategies that are important, in particular in larger communities, include telehealth. Telehealth is a really important tool. In Oklahoma, each family gets an actual, they get an iPad for families that have a hard time connecting so that they can connect to someone 24/7. That's every family who's been connected to the mobile response team. That's how they do follow-up. It's really helpful strategy, in particular around dealing with some of the rural communities. You talked about co-location, and satellite locations are important, and broad-based teaming, which means that we try to team with anybody that we can. So let's talk about money, because people always ask about how does it get financed and who pays for it and all that good stuff. Let me start by saying New Jersey made the commitment early on that every family would be eligible for mobile response and stabilization, regardless of whether they met the eligibility criteria for Medicaid or they were uninsured, their commercial insurance programs didn't pay for it, all of that. We paid for every child to get mobile response and stabilization. They had such savings in the upper tiers of the higher intensities of service. They were able to redirect dollars, state general fund dollars, to support mobile response and stabilization, and continue to do that today. But here's some potential sources just to think about. Medicaid is certainly one. Commercial insurance plans, and you can prove and demonstrate success with mobile response for those commercial insurance plans. Educational funds, child welfare, in particular now that they're moving toward the Family First Prevention Service Act, may allow for some of the prevention service dollars to be used for mobile response and stabilization. Is not yet an evidence-based practice, so it's difficult. It's not on the, it's not quite available. But however, it is a service that has a demonstrated track record and can be included with some of the prevention dollars. Mental health, state general funds, and federal grants are all ways. In fact, I am working with a state that just received a SAMHSA system of care expansion grant specifically designed to expand their reach in mobile response and stabilization. Some strategies to think about: braiding and blended funding, reprioritizing where funds are used, and state and localities may elect to blend or braid to address the needs of children, youth, and young adults. So just some ideas or some thoughts about how to pay. I can tell you that this is the best investment any state or community could make. What blended funding is, just so folks know, blended means that two payment sources come together and they're put in a pool, and you can't tell whose money is whose. So you can only track the outcomes, but you can't separate those dollars. Braided funding, actually you can, and you can track the funding stream and where those dollars were spent and what they look like. It's just important to have some level of understanding of what the finances look like and how the service gets paid. In most states, it's paid with Medicaid dollars for most children, and then some source of braided or blended funding. So let's talk about New Jersey for a second. New Jersey, like I said, is the system of care that many states strive for, in particular, just the elements, including the single point of access, the electronic health record, and all those kind of things. But the access to mobile response and stabilization in New Jersey is the longest sustained statewide access to mobile response and stabilization in the country. In other words, they have 20 years worth of data, which is really important in telling this particular story. So mobile was built from the beginning. It was built into the concept paper. It was built to keep children out of emergency departments. And let me just give you a quick vision of what it looked like in 2000 here in New Jersey. It looked like this. We had overcrowding everywhere. Every emergency department, every inpatient unit, the only state hospital. We had over 300 children in out-of-state residential care. We had overcrowding in the in-state residential programs that we had. We had overcrowding in every detention center in the state. That's just true. We also had one of the worst child welfare systems in the country, with the most amount of children that they were working with. Almost all of them were in some type of out-of-home. Very few were in their own homes. Today, that doesn't look like that at all, right? So the assessment process and the building of the cans allowed us to figure out what children needed, what they should get. The building of mobile response and stabilization as the upstream intervention allowed us to keep children out of emergency departments. So today, there's not overcrowding in emergency departments and patient units. In fact, there have been a substantial decline over the last 20 years of the use of those services. Close, the only state hospital brought all 300 children, over 300 children, back into the state for residential care. And since 2012 to today, they have reduced the number of children in residential care by over 1,000, which is well over half. There was 1,865. Today, it's 835. So just as an example of some of the things that have changed. Lowest number of children in foster care on psychotropic medication, closed 11 detention centers, and New Jersey has closed its first prison. Now, let me also say, there's still a ton of work that has to get done in New Jersey, but at least gave us a starting place of what to do. Every child in New Jersey is eligible under the age of 21. Under 18 require a parent to call. 18 to 21 require the individual themselves to call. Family defines the crisis. They say we need help, we go. And there's a verbal consent that happens. So over the phone, parent says, yes, you can come. And then the documentation is signed when the workers get there. There's a warm line connection, which means that the person who gets the call, the single point of access, connects with the actual workers who are going to go out. And the electronic record is started right from the start. A couple of really important things. The crisis assessment tool, the CAT, is used as the assessment tool. It's a form of the CANS, so it's connecting to the larger systems work that happens. Okay, and then just a couple of quick things. There's a local system of care that happens. So there's mobile response and stabilization, there's family and peer support, and there's connection to intensive care coordination using wraparound. The state manages the whole provider network. There is a connection to family support, which is important, and parents can actually connect to family support right up front. And so a lot of families connect to mobile because they connected to family support right up front. There's a training and certification process. There's ongoing supervision. There's also what we call super user groups, so we can address really challenges within the systems. And there's major collaboration that happens between the state and the local communities. There is a lot of work that happens with the psychiatric screening centers, which sit in the adult world in New Jersey. So you really have to work across those systems to make sure that every screening center is up to date, understands, is able to use mobile response. New Jersey has statewide implementation of the Nurtured Heart approach, which is a whole different story and a different day. Just important to know that there are some practice elements that became really important in terms of how we were going to engage and have conversations with both our parents, caregivers, and our children themselves, and how our partners across the system were going to talk to each other and treat each other in the work. There's a ton of collaboration that happens, which is important. And that includes with all the systems, juvenile justice, child welfare, and all that other good stuff. I'm going to skip just a little bit because some of these things are just really, really helpful, but not necessarily the thing that you're most excited about. But there is a ton of quality and outcomes that happen. So this is how we know. We were able to see the data, read the records, be able to track data over time using electronic record, both at the macro and the micro levels. We had dashboards and routine meetings and conversations with all of the partners. This is just some of the demographics so that you can see where our children are in New Jersey, just some data over time. This is the living situation that I talked about. COVID was not the driver. The 98% of the children staying in their own homes. You could see over time is averaged somewhere between I think it's 94 and 98%. 30-day readmission rate for children who are transitioned from mobile was tracked. We track that all the time, but they can use that service anytime that they want. So it's important for us just to understand what brought them back in. It's also important whether or not they get connected to the other parts of the system. This is the mobile response and stabilization trend pre-COVID, so it's important to know that there are some changes in this year's data. However, the data you can see year over year looks kind of the same. More children might use this service. However, there's always a dip between July and August. We're looking right now to see what's going to happen in September and October, as there's some debate about what school is going to look like. This is also the data on the children in residential care, which is really important to think about. So when I was starting, you can see somewhere it was around 1,860-ish children in residential care. Today it's 835 children in residential care today, according to New Jersey's own data. And a couple of really important parts just to think about as you're thinking about why this is important. For us, it was about keeping our children at home and school and the community. That's what is true for Connecticut. It's true in Oklahoma. It's true in Nevada, and a couple of the other states that I'm working pretty closely with around building mobile response and stabilization teams. It's not about keeping children out of emergency departments, not just because of COVID and not just because it's expensive, but because it's traumatizing to children and sets them on a path we don't want them to be on. So a couple things to keep in mind, and this is what we have learned from New Jersey. We have learned that fewer children are in residential interventions, and they stay there for a shorter period of time because their first touches were more gentle in the system. And they believe the system can be helpful for them. And at the end of the day, they believe that they can feel better at the end. There are few children accessing inpatient treatment. We closed the only state hospital. We reduced, actually brought all our children home, told them they were important. They should live in their own communities. We ensure youth receive the right intensity service at the right time for the right duration, which is really important, and why mobile response is so important, because it helps you start that conversation right from the start. What got you to call us today? Fewer youth in detention centers, wraparound work, so we know we can connect to wraparound. So just a few reasons on why this is all important. So I think I have hopefully made the case on why mobile response to stabilization is an important tool, but I'm gonna stop sharing and take questions.
Great. Okay, the first one is from Don Pooster. I'm sorry if I don't pronounce all of your names properly. I 100% agree that many children are best served in the community-based programs instead of high-ended services like acute care or residential. However, this can be a significant shift for clinicians and practitioners, and sometimes a philosophical difference. Even with good clinical evidence in specific crisis situations, our level of care is the best recommendations. We often have differing opinions and concerns around liability. How do you address the need for this system shift change? Of course, assuming you have the appropriate resources in a community-based setting.
Excellent question. Let me first start by saying I probably was one of those clinicians back in 2000. I ran residential care and thought residential was really important. I ran partial care, which I no longer am the biggest fan of partial care, because I've come to learn that other things work better. And so the first thing I think we have to agree on is that at the end of the day, we want to get to the best outcome for children. And the second thing we have to agree on is that there are different ways of thinking about it. But the number one thing we have to do is we do have to keep our children safe, but we also have to recognize that inpatient and residential care do not equate to safety. They don't. They only equate, in fact, a lot of children get harmed in both inpatient care and residential care, as evidenced by just some of the data around what happens to children who have been restrained, whether seclusion, all of that. So we have to agree that only children who can benefit from a residential intervention should get it, and that we have to be able to articulate what that is, right? Not just from our perspective, but from the child's perspective too. And I believe that that can be done. I know that I've done it for years. I've asked children what they think would happen and what it would look like. So that's our first part, right? The second part is when you talk about liability, you have to remember that you're building a team, a group of people, lots of eyes who are going to help you sort of sort this stuff out, and that you're going to come together to build the best plan. And let me just give you my experience. I sat as the assistant commissioner for New Jersey's Children's System of Care for over 5 years. During that 5-year period of time, the only children who got harmed in our system were in residential interventions and inpatient care. They were not in any home and community-based services. They were not getting intensive in-home or intensive care coordination or mobile response and stabilization. During those 5 years, I didn't have not one staff member from a mobile team get harmed. Not one care manager got harmed to the point where I would know about any of that. So, and I would have learned about that. I met with every single one of those directors on a regular basis. That's not where it works, right? Where it happens, where people get hurt is when we push kids into situations in which they feel pretty desperate and pretty lost. And we have to figure out how not to do that. And that's why mobile response and stabilization is so important, because it helps us figure out how to communicate, how our youth have a voice, and we include that voice, huge within the context of the work. I'm happy to talk about individual situations. If you want to reach out to me separately, we can talk about how to engage some of those clinicians. But just so you know, transformation can happen. I was one of those clinicians, so it can happen.
Thank you. Our next question is from Beth Boyle. Do you use youth and/or adult peer support on your response teams?
Yeah, so New Jersey was built before that. So, but although they're building it in now, which is really going to be positive, it's going to be awesome when they do. But I also work with multiple states that do use peer support, parent support as one of the tools. And they're building, I'm working with a state that's building youth peer support, which I'm really excited about. Those are young people over the age of 18 that they're bringing into those teams. So we'll see how that goes. But yeah, there's a lot of work that's happening across the country around that.
Thank you. We have two questions from, I want to say, Dania King. First question is, does the crisis mobile response address/attend to AOD issues and concerns?
Yeah, great question, by the way. Yeah, so I was also responsible for the substance use treatment system. Mobile response does bump into substance use. Almost, a couple of things the lessons that we learn in building an integrated system. Number one, when mobile teams go out, they don't always know what the level of functioning and what the level of substance use is. And so we built actual structures into place for when mobile teams bumped into substance use and what they should do, which included a rapid response clinician that was part of our network, would go out and actually do a full-blown assessment and recognize whether that individual really required inpatient care immediately, because we had concerns particularly around opiates and a couple other substances. So yeah, we had to interconnect those systems, right? Make them work together, but it is part of the assessment process. We look for it.
Thank you. Her second question, it was mentioned in this seminar that we don't want police officers to put handcuffs on the child. And in the last seminar, Mr. Bruno mentioned how that could be traumatic to an individual with mental health issues. How can this be effectively communicated to police departments / officers that insist that they are going to handcuff the individual no matter what? Great
question. So this is why you want a separate kid system. I'm just gonna because we wouldn't want to use the police at all, right? We don't find that that's part of our work together. It's very rare that police have to respond, and it was in less than 0.1% in all of the calls in New Jersey over my 5 years there, where we would even think about using police to respond with the mobile response team. So let's start there, right? How do you get those calls from parents in a more proactive way so that you don't have to worry about the safety of the workers who are going in? Two, you have to train. You have to train those police officers that when you're going to respond together, that you're the lead. They're not the experts on children. They're not the experts on children's mental health. And you are. And so they're there for a particular purpose, right? And so, and we were able to train all of our local law enforcement folks around that, but it did take years to get there. Okay, that's two. Three, you want to provide feedback whenever they do put their hands on kids, right? What happens to that child, what the experience was. And you want to make sure that you take that to the highest level of law enforcement. So as an example, early in the system here in New Jersey, I had a 15-year-old who was cuffed and taken to a residential interview in handcuffs. I went to the judge who ordered that to happen, and had a conversation with that judge about how they made treatment now incredibly more difficult, and that we had 5 strategies that we could have used prior to getting there. So we need to use education to help those partners know how everybody can be safe in this work. But like I said, I've been at this work for a long, long time. I have never seen the value of putting handcuffs on a child, not one, not in my 30 years.
Thank you. We have another question from Dawn. Tennessee Fund Mobile Crisis Funding Firehouse Model through a partnership with the Department of Mental Health and Medicaid. Grant staff based on Medicaid enrollment numbers. It's been in place, oh, I think this is more of a comment. It's been in place since 1993. She believes it's a very robust system. Okay, thank you.
Yeah.
Maggie Tolbert's question. What changes did they make due to COVID-19 as to delivery of services?
Yeah, great question. So in the beginning, it became really challenging. And as you might notice, New Jersey is a hotspot. So is Connecticut. We're in the hotspots around COVID early. And in the early days, they actually were only doing virtual work. But one interesting thing happened, the requests, the numbers of calls dramatically dropped as well. So they had these 2 interesting dynamics happening at the same time. In Connecticut early on, they actually put all the mobile teams actually used, they got personal protection equipment. They were considered emergency personnel, and they went in and did and worked with young people and their families, and it was powerful. It is probably the right model to use, in particular for mobile response and stabilization. New Jersey didn't do that early on. They're doing that more these days, but they're finding that some of the youth that they did not get to have more complex needs now, and they're really have to work hard to de-escalate these situations that have been going on for a while.
Thank you. Next question is from Precious Stubbe. Can you address the concerns regarding safety and going into the home? This is a consistent hurdle we hear from providers.
Sure. Well, let me just, okay, so I love this question, and I've gotten this question for many years. As I said, I've been at this work for a long time. In my 5 years, no one ever got harmed. I worked in home for many years and was never even thought that somebody would I mean, not that I didn't take my safety seriously. So number one, I think it's important to train individuals, right? It's important to train the folks who are going in home on what it is to go in home. What do they need to worry about? What do they need to be thoughtful about? And you need to actually think about not just the home itself, but the environment in which they go. I've worked in both urban communities in New Jersey where we train people on how to enter a home, what it will look like, where do you park your car, all kinds of things like that. And had to actually shift gears when I worked in the most rural parts of New Jersey, where then we were worried about the bears and when the bears are going to be there, and you got to worry about the animals. So you have to think about the environment in which people are walking into. The next step, though, is you have to remember people are inviting you in their home. And the first, how you engage from that first phone call tells you how the rest is going to go. And we used to think that the number one thing we should worry about were weapons in the home. And we learned that the number one thing we needed to worry about were dogs in the home. And we needed to have a conversation with families about what to do about their dog, right? I'm a dog lover, right? So, but if you came to my house and I was in a really agitated state, my dog's going to protect me from the strangers walking in, is the way that we explain it. And families are receptive to that. We also talk about whether the environment that you're going into is safe enough for that employee, for that worker to go into, and whether or not you need to think about the first meeting taking place someplace safe. But that's a conversation that happens with families, and it works. And like I said, we've been really fortunate, but I think really prepared. I like to call it belt and suspender prepared, by having well-trained staff who know what to look for and what to do, well-trained supervisors who are supportive, and recognition of engagement with the youth and the family up front is just really, really important. We're helpers, and people want help. That's why they reached out in the first place.
Thank you. Our next question is from Travis Atkinson. Are the 94% rates related to diversion from hospitalization or from changing housing situations, example, foster care?
All of it. It's all of it. So means that if the mobile response team goes, the child stays where they are in that because they respond to the home, so they stay in that home. That includes children in foster care. It also includes children who might need a visit to the hospital. I'm going to say that the majority of the moves in the 2% are actually to other family members. They're generally not shifts in foster care, and they're generally not shifts to the hospital.
Thank you. Next question is from Kayla Fortman. What is the biggest difference between a youth-run mobile response and adult-run mobile response?
I think the biggest is who defines the crisis, right? In the adult model, you could have the adult defining the crisis, but in the kids model, you have the parent or caregiver who's defining the crisis. And because they're not the individual necessarily in crisis, they've been watching it. They've been paying attention. They've seen the shifts, the changes, all of those kind of things. So you're really listening to the adults around the child. And the other really important thing that's different in adults and kids is who sits around the table, the inclusion of the child welfare system, inclusion of the school, inclusion of the juvenile justice system. They are partners in at the table. You speak the same language, you communicate the same way. Really important components of adults versus kids.
Thank you. Next question is from an attendee. If we can revisit the insight you shared regarding youth being misdiagnosed, do you see youth diagnosed with OOD and the proper diagnosis is PTSD?
Of course, yes. I've seen it all, and early on in the building in the New Jersey system of care, it was striking to folks who were really working in the system of care how diagnoses differed between hospitals. So some kids would be diagnosed with oppositional defiant disorder in one community, but if they had moved over the line, they would have been diagnosed with post-traumatic stress disorder, and they were getting different treatments because of that. And that was really, really important for us to be attentive to. It also made a huge difference for kids in foster care, by the way, because it allowed us to really think about whether medication was the right tool for them right up front, or do we need to try other things?
Thank you. And our last question is from Brooke Sherman. Well, we have one more after that. How do you recruit and retain workers from a MRSS due to it being 24/7, meaning there are evening and weekend hours that need covered?
Yeah, great question. So, and you know what, we let organizations actually figure that out, but some of the strategies they've used over the years, number one is you get folks who really are interested in this work. Two, a lot of the folks who work in mobile response and stabilization are interested in the hours because they want to go back to school, because they want to learn this work. It's a great entrance into some of the other work because they're well trained, well supervised, and well supported. Majority of mobile response teams in New Jersey end up going back in school, and so this is a way for them to be able to do it. But they also have other incentives as well. They pay, they do have a differential rate in some places where they pay for folks who are on call, they pay for weekends, they pay for holidays, those type of things. So there's a couple different strategies that can be used.
Thank you. And our last question is from Beth Kuchek. Do you find it necessary to diagnose in order to be reimbursed by Medicaid and insurance?
Great question. Yes, it's been the debate in New Jersey for about 20 years. For mobile response teams, they do need to ultimately land somewhere, right? Because of Medicaid, they need to land somewhere, but the assessment process is enough to push them forward around a diagnosis and what they can come up with as a diagnosis. And they use some diagnoses that are less intensive for children to begin with. So yeah, it is important. It's an important part of the conversation and it needs to get addressed. We like to think about it in New Jersey as a backdoor issue. It's a backdoor issue because we got them the service, they got what they needed, and we've been able to move on. And we don't put the heavy duty post-traumatic stress kind of diagnoses on kids who enter only through the mobile response door.
Great. We have another question that just came in, if you don't mind. It's from Karen Kimbrough. Have you worked with many individuals diagnosed with fetal alcohol spectrum disorder, FASD? Many FASD are misdiagnosed as well.
Yes, we agree. We agree, and we see that, and actually both of them, we added fetal alcohol to the screening tool that we use right up front. We ask a lot of tough questions around fetal alcohol, which is really complicated, and we train folks to do that. So we may not get to that early in the work for mobile response, but it's definitively in the work for youth who enter intensive care coordination. So that means they're either at moderate or high risk. And so it is built into the screening tools that we use in New Jersey. And we did see a large number of children who were misdiagnosed.
And another question that came in from a Janie Minot. What licensure level is required on the teams if they are diagnosing?
Sure. So let me remind you that bachelor's level folks go in, so they're not doing the diagnosis, but they are supervised by licensed clinicians, the highest level of licensure in New Jersey. Those are the folks who are actually doing the diagnostics.
And Jill has a question. What types of situations have caused a need for police involvement in the less than 1% of the situations where you felt they were needed?
Yeah, that would be really kids who are demonstrating very aggressive behaviors toward parents or communities. Give you a quick example. We had a young man who was really struggling and grabbed a weapon. He had an accident, attacked a car, threatened his mother. Those are the kind of situations we would use the police.
Okay, final chance to put in a question. If not, I just want to take the time to thank you for a wonderful presentation, and your time and energy that you've devoted to us is very much respected and appreciated. We do have one more question, and since we have a few minutes, I'm going to go ahead and allow it to happen if that's okay with you.
Yeah.
Jill asks again, what ages of youth are addressed by your team, and how are the calls routed to your team rather than the police?
Sure, great question. So New Jersey allows anyone from 4 up. In fact, children going into foster care, it's 4 and up for mobile response. There are some caveats for under 3 to use mobile response. Usually that's identified by the medical director who's available 24/7. For the single point of access. And the calls all come in through a single point of access. So there's a 1-877 number that parents are given, they can call 24/7.
Great. Well, again, thank you for your time. And I want to remind everybody that all of these presentations will be posted and all of the unanswered questions will be answered. So thank you again for your energy and your time and your presentation. Very much appreciated. I'd like at this time to turn it over to Wilma Townsend, who will be introducing our panelists for the next section of this webinar. Wilma?
As part of MRSS, as part of our system of care grant, we ended up contracting with a marketing company to come out with an animated tool that could easily be understood by anybody in the community, so that families could see that if they were having any problem with their child, that MRSS was a place that they could come. And we wanted it to be simple enough that it wouldn't scare people away and make it so that they're very understandable. So hopefully we'll be able to get that fixed, and you'll see it at the end of the presentation. Let me also say that Ohio was one of the states 4 years ago who received the Systems of Care grant, and we ended up as a part of that Systems of Care grant where we funded the Northwest, some of the counties in Northwest Ohio and some of the counties in Southwest Ohio to start implementing mobile response stabilization services. And we have 2 of the providers who have been implementing this in Ohio. We are now at the end of our 3rd year. We've learned a lot. These providers have gone through a lot. and we want to share with you what all they had done and some of the accomplishments. And then hopefully we'll be able to see the video after that. We're going to start with Lisa Ashafa. Lisa is the Director and Peer and Specialty Services at Coleman Professional Services. She supervised the mobile response team and that covers Allen, Auglaize, Hardin, and Putnam counties. She has a master's degree in criminal justice. She holds a CDCA and in the process of obtaining her LCDC 2, and is a certified peer recovery supporter. She has been with Coleman for over 5 years now and have worked hard and diligently to grow the peer support services in her area. She supervised 2 drop-in centers, the quick response team, and the SUD recovery coach team. Recovery is possible for anyone, and she is blessed to be one of the folks that folks allow her to serve them. Let me introduce you to Lisa. Okay, Lisa.
Thank you, Wilma. Let me get my screen shared here, folks. Okay. When they asked me to do this on Zoom, I was, let's just say, scared, because I'd rather talk in front of 1,000 people versus on this computer. So, like Wilma said, my name is Lisa Ashafa. I am the supervisor here at Coleman Professional Services. And we service Allen, Auglaize, Hardin, and Putnam counties. I would go over, my first slide is just about what mobile response is, but I think that the other 2 presenters, Elizabeth and Rob, have both pretty much summed up what youth mobile services can be. We started youth mobile response, I believe back in 2018, at the end of 2018. So when the board came to us and said, you know, what do you think about doing this new project called mobile response? First we were like, what is it? You know, it's helping kids and families who are in a self-defined crisis. What's a self-defined crisis? Well, that depends on the family. It's not your typical clinical diagnosis of, you know, suicidal or homicidal. It is anything that the family is going through at the moment, whether it be they can't get their kid to go to school, or maybe the kid is staying out late at night, not wanting to come home at all. You know, whatever the crisis is that's going on in the family's home, they define it. We serve kids birth to 21 years of age. And let me say this, I forgot to say that at the beginning of my presentation. So you're going to see pictures of kids along my slides, and I tried to incorporate pictures with their faces blurred. I know it looks like masked, but it's not. I blurred their faces for privacy, even though we have consents signed by their families. I just wanted to still protect their privacy. And some of the pictures will give you kind of an idea of like different outside of the box thinking that we've had to do with kids. I don't know how to go back. I messed up here. How do I go back a slide? Either way, let's not worry about it. So what do? We enter a family's home when the referral comes in. We've had different referral sources from all over the community. We go into the family's home with their permission. We prefer to meet in the family's home. Some families have initially not wanted us to come in until they've met us. So we've met them at places like McDonald's or the public library or the park, just to have that first meeting to allow them to get to know us as a team. Our team is comprised of a clinician and then 2 peer supporters that both have had some kind of an experience in a system of care themselves, whether they, the parent, had their children involved in the system of care, some system of care, or they themselves was a child in a system of care. So we go in together to meet the family and to find out what's going on. And we hear both sides of the family. We hear the caregivers. And I don't like to use the term parent because lots of the families that we serve, parents aren't raising the kids. We've served aunts and uncles and foster parents and grandkids. You know, nowadays you've got grandparents raising great-grandchildren. So I like to use the term caregiver. So we allow the caregiver to give their side, and then we have the youth give their side, because many times kids don't have their voice heard. So we try to sit with the whole family unit together to get a clear picture of what's going on in the home. Some of the things that we've done with kids is we've connected them to different resources. We have found that many of our kids are bored. They've suffered from generational trauma, generational poverty, you name it. The list can go on. And so, like Elizabeth said, sending a kid to traditional residential treatment isn't always the best fit for kids. Getting them to think outside the box and do different activities to learn how to express themselves and talk about things, it's hard for kids. So if you get them involved in an activity where their hands are busy and people aren't just sitting and staring at them, we found that they're able to open up more. So we've connected kids with NAMI Youth Move. We have a Safi drop-in center for youth here in Lima. We get them connected there. We've done things like having kids give back to their communities where they've assisted with food pantries and holiday parties. And we got kids connected with a summer youth program through PASS, which is another prevention agency here in Lima, where they have a summer youth program to get them involved with other kids and doing things differently than what they're used to. We got kids connected with a summer program where they took boys out and helped mow elderly people's yards. And so in return, they earned money. And so then that money, like the picture in the bottom left corner, this is a young man that is shopping for his first Mother's Day gift ever. He's never been able to buy a gift for his mother, which is not his biological mother, but his caregiver. But he took his money that he earned with the summer program and learned how to buy something for his mother for the very first time. And it was through his work that he did that. And when we got that family, because mom and son were just at each other's throats, you know, the 15-year-old, he just knew what he was doing. He knew everything about life. You know, at that age, you can't tell kids much, but so we had to get creative with him. So those are some different things that we've done with kids. How our process works is we receive a referral from either our crisis hotline or from outside community entities. And then we send a family coach out to meet with the family. They're connected with the family within 24 hours, along with the clinician, and they just talk and have a conversation about what's going on. They safety plan. That's the biggest thing right up front, is safety planning to make sure that all people in the household are safe. We explain the duty to report if there's any suspicion of abuse, neglect, and mistreatment. But we also try to explain to the family that we're there for them, that we share our own experiences as people in recovery, and try to help come up with some type of a plan to move forward. We don't like to overwhelm families on that very first meeting, so it's pretty much just a conversation and safety plan. And then we ask the families, are you willing to meet with us again? Typically, yes, they are. So we schedule a meeting number 2, and then on meeting number 2, we take care of all the formal forms that we have to do, and then we get rolling with helping the families. We can keep families open anywhere from 24 hours up to 6 to 8 weeks, depending on the family's needs. If it goes past the 72 hours, then it rolls into what we call the stabilization phase. And that's working with families over the next weeks to try to help structure that family so their self-defined crisis either doesn't happen again or isn't as bad as what brought us into the home in the first place. We let the family defines how they want us to help them. They outline goals. They'll say, I need you to help me with X, Y, and Z. And then we think, how can we help you do this? We do a lot of connecting to different community resources. You'll be really surprised how many people in your surrounding communities don't know what's out there for them. So we don't do this stuff for them because we like to empower families to do things independently, but we will give them all the resources in the world and then support them to ensure that they make those resources that they choose. And then towards the end of whatever time frame we've designated, we do what we call an exit plan. And the exit plan consists of the goals that the family outlined, the progress that we've done to help that family, and then what they're going to do once we're gone. And within that exit plan, though, what they're going to do when we're gone is we outline different supports that we've connected them to in hopes that they would continue to follow the plan on their own. We always explain that mobile response is always available to them if they feel like something happens down the road and they need us. We give them the hotline number, we give them our flyer, and then we close. We try to connect families, if they're willing, to the Family and Children's First Council, because that's a kind of a wraparound service that can continue with them. So that's pretty much what our process looks right now. I know the model has like 4 different levels of response, and Coleman's mobile response team right now here in Allen, Augley's, Hardin, and Putnam, we're only at the information and referral and the non-immediate phase. We don't have the staffing ability right now to move to a 24/7 service. And I was happy to hear Elizabeth say that, it starts out small and then it grows, where we're still in the small phase. So we look forward to what our future will bring. So that's pretty much what the model looks like there as far as what a 24/7 mobile response crisis system would look like. Where do we provide our support and assistance? Wherever the family will allow us to meet them. Again, we've met with them in the library. We've went to the courtroom with a kid. We go to the juvenile detention centers to go in and talk with families, CAST meetings. I mean, you name it. I don't think there's a location that we've said no to yet. So meeting families in their home is what we prefer, but we respect their wants as far as strangers coming into their home, like right off the bat. So we meet them where they're at and in hopes that they'll invite us into their home, because getting into their home will truly give us a better picture of what we're working with. Let's see here. How do we help? So we help by trying to reduce the number of times law enforcement is involved, how many times families take children to their emergency rooms because they feel like they have nowhere else to go. We go to them. We go to families. It's not your traditional inside an office. I mean, they can get those services with many other, phenomenal programs throughout our communities. So we go to them. And one thing we like to stress is that, you know, typically when you see a kid's dysfunction or a kid's negative behavior, it's a symptom of family dysfunction. Something's going on in the home that's causing this kid to act out. And we only have anywhere from 24 hours up to 8 weeks to try to get in and move fast, figure it out, and try to help this family in some way, shape, or form. At the same sense, we know that we're not going to fix families. You know, we're dealing with families who have, like I said before, generations of sexual abuse or trauma of different kinds, generational poverty. I remember I had somebody ask me when we first started our mobile program, like, do you see a lot of substance use? And I said, no, not really. In the families that we've served, substance use hasn't been an issue that we've seen so far, but poverty is the biggest one. You know, when families lack their basic needs, it's hard for kids to function, it's hard for parents and caregivers to function, and it's hard for them to function together. So many a times we've taken families to food pantries and connected to them to their resources, because if they don't have their basic needs met, how can we ever expect them to grow past whatever is happening? And the use of peer support with our team is powerful. When our staff shares their own personal experiences with these families, it levels the playing field. We call it peer power. So I remember we had a referral from an outside entity, and the peer supporter tried for a week to get a hold of this mom. Open Children's Services case for 4 years. Mom was dodging us left and right. And I finally got a hold of her and I said, listen, just give me 5 minutes to tell you what we're about, just 5 minutes. And I started it off with, my staff were moms just like you. One of my staff had an Open Children's Services case. She lost her kids and she fought tooth and nail to get those kids back. So she knows what it's like to have an Open Children's Services case. She knows what it's like to lose your children and feel hopeless. You know, she understands these things. So if you just give us the opportunity to come to you and tell us and let us tell you some of the ways that we can try to help you, that's all we're asking for. She cried on the phone. She was very transparent and said, you know, I feel like everyone that's came in the home has went back and reported to X, Y, and Z and taken my words out of context. And I just want this to go away. I said, okay, well, if you want this to go away, will you let us come to you? And she said, yes. So it took us a few times, but it really took me saying to her, my staff had an Open Children's Services case when she was younger, and she managed to get that Children's Services case closed and her kids back in her home. And it gave her like some kind of hope that that there was an end at this dark tunnel. So, I mean, peer support is a true asset to this program. We received our first referral in August of 2018, and we kind of didn't know what we were doing. You know, we just kind of flew by the seat of our pants. Like, okay, we knew that we just wanted to help kids and families. So how are we going to do it? Trial and error. You know, we may fumble, and if we fumble, we tell the families, we fumbled. We messed up there. We made a mistake. Let's try this, you know, because being real with these families allowed them to see, okay, you guys truly are trying to help us. As of July 1st, we have served 113 families across the 4-county region. And I only intentionally put that data in there because that's 113 families that have allowed us to come into their homes. That's a lot of families that have opened their doors and said, yes, we'll allow you to come in. We've only had 9 families that have said, not right now. I got too much going on. I've got too many people that I got to report to, too many people at the table, and it's just overwhelming. And for those 9 families, we've simply explained to them, okay, if in the future you need mobile response, this is how you activate it. Please know that we're always there to help you when you need it. We've got referral sources from Family and Children's Service Council, Juvenile Court and Probation, Child Protective Services, many local school systems, the other community mental health providers for children in our areas, medical health centers, homeless shelters, and then different community centers. So the word is out there on mobile response. We need more manpower to handle the number of referrals that are coming through the door. We average about at least 2 a week, 2 new families a week. So the news is spreading fast. So I'm happy to hear that our community partners are also utilizing our service. Strengths of the program is we're flexible. We try to meet the needs of the family. That means that we don't work your traditional Monday through Friday 8 to 4. Our team offers both clinical and peer support. We've got lots of positive feedback from families and our community partners. The most recent one was from our FCFC council that said that she sent an email to our peer supporter saying that the mom said she was a miracle worker because she's been in a house that I seen pictures like she shouldn't be there with her kids. Rats underneath the stove. She's tried calling housing authority. It's just this ugly situation. So within, I think it was 3 days, my staff was able to find this mom and her 4 kids a new home. They're getting ready to move into a nice home where there's no problems in it. And so then mom can get her family back on track. Another strength of our program is that they are, we have a lot of connection with our different community entities in our counties. They look to us for help when they're not really sure what to do with a family. Some of the weaknesses is that the number of referrals coming in the door keeps us really busy, that we don't have much room to like spread the word that we want families to be able to call in to the hotline themselves instead of having, community entities refer us, even though that's not bad. I'm not saying it's a bad thing for community entities to make the referrals, but we really want families to call us on their own. We want families to activate the service themselves. Because Coleman here in Allen, Auglaize, and Hardin is not a child mental health provider. We wonder about how we're going to sustain it down the road, but I have no fear that our state folks will make this happen for us because we know that children and families need this service. There's a shortage of licensed clinicians across the board. So having a clinical person on the team around the clock, thinking forward, it may be difficult. I liked that Elizabeth shared that they used bachelor's leveled people who reported to a licensed clinician. That was like, ding, ding, ding. Okay, I took that point away. So thank you, Elizabeth Manley, for that. And then one of the questions to her was, how do you sell this to staff? It's not traditional. How do you say to a clinician or a staff, you're going to work crazy hours. You're going to work with really intensive families. You're going to go into environments that may not be the best. And it's community mental health. And the pay may not be that great. So come on board. How do you sell that? You look for people who are tired of working in an office. You look for people who are passionate about working with children and families. Like those are the people that you have to go for. We hit the jackpot right off the bat. We had 2 peer supporters that was so willing to jump on board and do their thing. And we had a clinician that was sick of doing clinical work. I'm going to skip by here because I know I'm pressed on my time here. I am a talker. So if anybody wants to hit me up at the end, I put our contact information. Our hopes is to eventually run this program to a 24-hour service. This is some feedback that we got from families. These are actually different little art projects that the kids made and gave us for just thanking them for being heard. We had a parent say, I feel like I've finally been heard by someone. And this is our contact information. Anybody wants to follow up with questions, it's mrss@colemanservices.org. And we use our HOPE line. It's 1-800-567-HOPE. We give that to families out in all the communities if they want to activate mobile response. So thank you. I'm sorry I flew through that at the end, but I just was pressed on time.
Thank you, Lisa. All right. Now we're going to have one of the providers from the Southwest region to present. Her name is Rebecca Tuck. And Rebecca had been in the mental health field as a master's level therapist since 2009. She has experience in servicing children, adolescents, and adults in community-based and outpatient settings. Rebecca served as at the Solutions CCRC for over 6 years, included in the role of school-based therapist and crisis therapist at the Warren Clinton Jail before moving into the role as an outpatient program supervisor. For the past 3 years, Rebecca had worked as the addiction therapist at Linder Center of Hope and has experience facilitating intensive outpatient groups. Rebecca came to Butler Behavioral Health in January 2019 as the program manager for mobile response stabilization services. Okay. So let me turn it over to Rebecca at this time.
Thank you, Wilma. It's just a great opportunity just to talk about MRSS and what we've been able to do here in the Southwest region. So in the beginning, before there was a mobile response, there was, for kids, there was a 24-hour crisis response available to the region, but we were noticing that crisis workers weren't necessarily trained specifically in family systems and children and youth interventions. And that very few children and youth were served by this crisis response. Also, over the 4 different counties, there was a variability in the response and availability. And then what was happening as well is that hospital screens and those higher levels of care were being accessed. So our team began providing services December of 2018. We provide one consistent intervention across 4 counties. And this has been a unique opportunity because we have 3 different county funding boards that have joined together to help to make this a possibility. The after hours, including evenings and weekends, began in February. So our hours of operation are 8 a.m. to 10 p.m. Daytime team has myself as the program manager, 3 licensed clinicians. One of those is a bachelor's level, the other 2 are masters. And then we have skill builders and peer support specialists as well. The after hours team includes 7 licensed clinicians. We run 2 different calendars for the evening and weekends, one for the Butler and Preble side, and then one for the Clinton and Warren side. For us, how it works is the first step is that the family calls and they will call the hotline. There are 3 different hotlines in our region, and they will talk to a trained staff person about what's going on. That staff person will take the information. That hotline, again, is available 24 hours a day, 7 days a week. Then the staff, MRSS staff person will be, the hotline will reach out to the staff person. The MRSS staff person then will arrange to meet with the family. We respond within 60 minutes to wherever the family needs. Most of the time that is in the home. Upon arrival, we work with the family to de-escalate the current situation using a distress cycle, de-escalation strategies, as well as family systems interventions. We stay for as long as we need to. We could be there for an hour, we could be there for 3 hours, but we want to make sure that this family's current distress or stressors have been soothed, and then we schedule a follow-up if necessary. Once that situation is calm, we can offer up to 45 days of intensive support, including linkages, referrals, skill building, peer support, and short-term therapy. A note about collaboration with law enforcement. So we generally respond to the situation without law enforcement. We do access when there is a safety concern, such as domestic violence or a weapon in the home, or the situation is escalated to the point of needing backup or support. The other situation we'll work very closely with law enforcement is if they've already been to the home and they're calling and referring us, and so they'll be hanging while we respond with that family to get them hooked up with services. I know that that's been a topic this morning as far as the safety concerns. There's only been one time in the last 18 months that a therapist felt like he needed to step outside and call. Police were there within 4 minutes because it had gotten to a domestic violence situation. And the other part was we were on our way, but it intensified to the situation where kiddo was threatening the dad with a hammer or some kind of tool in the garage, and we called police to help us with that at that point. But generally, we have not had any safety concerns, and it worked well with law enforcement when needed. So we go for O's. I have a box of Cheerios in my office, and I use the scenario that if a mom with a 2-year-old calls because her child spilled Cheerios on the floor, that may not seem like a crisis to me, but it is still something that if she's calling, we need to respond. So we go no matter what. We don't ask why, we just go. The family gets to define what that crisis is. In other words, we don't screen out, we screen in. And so we've responded 94%. The requested immediate responses were seen within 60 minutes. Outreach was made to 100% of those referrals that we've received, and 76% have been served for all of the referrals. My staff is trained on trauma-informed care, as well as interventions for youth with developmental disorders and autism spectrum disorders. We know that for every action, there's a reaction, and that stress impacts the whole family. So our intervention really focuses on identifying family patterns, not just the immediate crisis. The example that I use is from my own life, going to Costco with my 3 children. My husband is blind. I have 3 children, 17, 14, and 8. And I'm rounding the corner. My 16-year-old says to my 8-year-old, hurry up, Malachi. And my 14-year-old says, let's go, Malachi. And then my husband, who didn't hear or see anything, says, let's go, Malachi. Well, Malachi's going to get upset in the middle of Costco, right? And I can snatch him up and I can yell at him, or I can be upset with him. This is a family pattern that it's a bump, 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 right? That everybody's really kind of impacting my son Malachi to get up and hurry up and do something very quickly, and he doesn't have enough time. So that's like an example of what my family pattern is. So we as a clinician, as a team, try to help other families to kind of go, what's this pattern? Because if we can get at that pattern, we can address this immediate situation. If we can get at that family pattern, then we can impact your family and maybe help you to make some different changes. We also work to look for their felt needs, identify those, and put supports that are needed for long-term success. That could include referrals to wraparound, parent peer support, substance use, community support groups. And so 72% of our families received referrals. 46% of those had begun by the time that we ended our services. And then we had 64% engage in the ongoing stabilization services. One of my jobs jobs in particular over the last 18 months is to really work with community stakeholders. And so I've gone to over 100 promotional meetings in all 4 counties in the past 18 months. This has included school, law enforcement agencies. I've participated in roll calls. I visited Alternatives for Violence, outpatient and school-based counseling agencies. We've reached out to kinship navigation supports, Boys and Girls Clubs, a youth cafe that was in Preble County, Cincinnati Children's. And so you can see there's a lot of community stakeholders in this region, and we have worked really hard to identify that referral process, get this into the hands of those stakeholders and eventually into the hands of the families. So we also have a cohesive marketing tool for the 4-county region. If you go to www.mobileresponse.org, you will find resources there, a brochure that you can download, as well as frequently asked questions. Our regional project director, Heather Wells, has led the way in partnering with community stakeholders and a marketing firm, Reverb, to create a streamlined marketing, because we want this information to get into the hands of families through social media posts and through referrals. Another really interesting thing is that we've had little notebook cards that we have distributed to law enforcement. It's a little notebook that fits into their pocket of their uniform. They can pull that out and rip off a page and give it to the family, and it has our information, our contact information, how to get a hold of the hotline, and so that it's an easy referral for law enforcement who may be in the home after domestic violence or something has happened, to be able to make a very quick referral to the family that is in need. So some examples of working with the community stakeholders include Warren County Children's Services. So for over about a year now, we have worked with Warren County Children's Services whenever a child is placed in foster or kinship care or has been exposed to an overdose where the child was present. Warren County Children's Services has given us a direct referral. We have an established MOU, a memo of understanding with the Children's Services there, just to further solidify that partnership. We get to respond and call that foster family or that family that has a safety plan, explain who we are and how we might be able to be helpful, because we know not only has the trauma that happened, but maybe something in the sense of a family has, a child has also been placed, and both that and the trauma can really be impactful. So we want to patch that up further stream and prepare maybe that foster family or that kinship person to be looking for those behaviors that might come up. We work with wraparound and care coordination. We're included in all of the safety planning for all 4 counties when wraparound makes safety planning for families. And so we are also in the process of identifying and coming to a memo of understanding for all of the teams that are wraparound teams to solidify that referral process as well, and to really work closely with the wraparound teams in all 4 counties. Another example is for local school districts. So for example, Lakota School District has included the MRSS in their decision-making tree for students that are in distress. East Elementary School in Eaton in Preble County provides direct referrals for students with emotional behavioral concerns. And in many schools districts, we respond when a child or a youth has de-escalated during the school day, and then we work to link that child and with the family after the school day is over.
Rebecca, this is Joyce. I hate to interrupt you, but we're running close on time.
Then I will just be done.
We will be posting all of the PowerPoints, and we will be forwarding all the questions to our panelists to answer. And Rebecca, we want to thank you for your time. We really appreciate it. The film will also be posted for review. I'd like to turn it now over to Sherry Walder for closing remarks.
Well, thank you, everyone. I want to thank all of our panelists. You all did a really great job We were so lucky to have such a great panel, not only of national speakers, but our Ohio folks who are actually doing this on the ground. So I really want to thank them. You will receive very shortly an email, and we would very much like you to make sure that you do your evaluation. We can only make these better if you tell us what worked and what didn't work. So we really want to hear from you. Additionally, if you need CEUs of any sort, you will need to fill out that evaluation. So we really want to thank you. Again, I want to thank our speakers. I want to thank the PEGS Foundation. I want to thank the Ohio Association of County Behavioral Health Authorities, my staff, who did a really good job, particularly Courtney and Michaela, who worked all this out. I want to thank the Ohio Department of Mental Health and Addiction Services for their continued support of educating folks around crisis services. So hopefully we'll see you again in a couple of months when we do our next crisis Zoom. We hope you all have a great day, and we really appreciate that y'all hung in there. We realize that 3.5 hours is a long time, but I think you got a lot of great information. So thank you all and have a great afternoon.